SEMA is a new generation of the neurosurgeons, the way forward, I think. So we have so many nice, the excellent experts today, speakers, especially Professor Robert Spitzer. So maybe I think I want to invite Professor Tari. You want to say something before start our symposium?
Yeah, thank you, Professor Yoko Kato. Hello, everybody, and welcome to this ACNS Young Neurosurgeons webinar or web symposium. So as you can see from the program, there's a galaxy of speakers who are going to be talking to you and discussing with you many aspects of neurosurgery, which nowadays are very important. Uh, Obviously, I would like to thank the organizers who have worked relentlessly to arrange this webinar symposium to do that. And obviously, my special thanks to Professor Yoko Kato, who is the force behind all this. Professor Yoko, I have to say, is a true global neurosurgeon. She has worked all over the globe for education and training for young neurosurgeons, and especially in this region. She has done so much in the last many years. And I should not forget, obviously, that she is following in the footsteps of Professor Kano, who initiated this program, and really amazing the way the students have gone to train in the university and with the equipment being sent to different places, most recently, of course, in Afghanistan and many other countries. So thank you very much to everybody, and I think we should begin this symposium. Thank you. You're mute.
Ben.
So Ben, so can you start the first speaker introduction?
His line is poor,
Yes.
I think.
So yeah. But I have agenda today. So thank you so much, Professor Kato and Professor Terkan, and for your kind introduction. So we'll start with our first speaker, Professor Robert Spitzer. Will talk about the vascular lesion of the spinal cord. And then our next speaker is Professor Zuniki Nakai.
So we cannot hear your voice, sorry. So can we start Professor Robert Spitzer?
Next generation approaches to drug-resistant epilepsy, talking about the basics and progress of neuroendoscopic hematoma evacuation. Shimura talking about the mechanical function. Okay. So
maybe Hui can pitch in. Hui?
Take over, Dr. Hui?
Yes.
So he's in surgery now, I think. So maybe Dr. Hui can take over, please.
Yeah, for the first
yes, please.
speaker. So we start with the presentation from Professor Robert Spessler, but he's not here.
Maybe Dr. Liu, do you know that? You received some link, something.
Yes, Prof. Ben has a video, Prof. Yes.
Can you start, please? So maybe then we can start, Nakai Sensei. Maybe during your the preparation,
okay, I will start. So can you?
Yes, thank you so much.
So I'll show my slide here. Can you see my slide?
Yes.
Okay, so let me start. Thank you very much for giving me such a wonderful opportunity for me. My name is Shunsuke Nakae from Fujita Health University Department of Neurosurgery. So today I'll talk about epilepsy surgery using a robot or endoscope or awake surgery. So as you know, seizures are mainly classified into the generalized seizure and focal seizure. And for general seizures, palliative surgery is usually chosen, while for focal seizures, regionectomy is selected whenever possible. So for focal seizures, the resection area and extent are determined by considering the concept of epileptic zone I explained later and the epileptic network. We perform SEEG, which is a robotic surgery in many cases prior to regionectomy. It is minimally invasive and enable broad cultural coverage. So we value this minimal invasiveness in our surgical approach. So we also perform regionectomy using endoscope or endoscope technique. If seizure onset zone are located near a eloquent area, we select awake surgery for resection. So first, let me introduce surgery for generalized seizures. And as I explained, generalized seizure, we can only do the palliative surgery and usually selected corpus callosotomy or BNS. The corpus callosotomy is the first line surgical option for drop back. The BNS can be indicated regardless of seizure type or patient age. However, it is generally limited to the left side. So I'll show you the surgical movie of the corpus callosotomy with endoscopic assistance. So this is a 5-year-old male patient who was suffering from the West syndrome, and he experienced so many drop attacks. So first, we separate in the hemispheric space, and you can see corpus callosum here between the two anterior cerebral arteries. And you can see this line. This is, I don't know how to say English, I'm sorry, but this is an important landmark. So this is the anterior part of disconnection. And this is the posterior part of disconnection. This is very, very deep. So it's very difficult to focus on. And this is the disconnection of the splenium area. But we need to retract strong. So we change the endoscope here. We don't need to retract very strongly, and we can easily see disconnection line like this. So it is very useful to check the disconnection line, whether disconnection was completed. So next, I'll talk about DNS. This technique was approved in Japan in 2010. An advantage of this technique, is efficacy increase over time, and it can be indicated regardless of seizure type and patient age. But disadvantages, battery replacement is required, and it limited to left side implantation, and the complications of BNS are listed here. So sometimes BNS is quite simple technique, but sometimes it is very difficult to detect vagus nerve because sometimes it's located prior to the common carotid arteries. So in such case, it is very difficult to detect. So our approach is using a fused image of MRI and 3D CTA and created the fused image and detect the vagus nerve before surgery. So this is an image of the vagus nerve. So this is a CCA and internal jugular vein here. So you can see a vagus nerve here. So we can predict the location of vagus nerve in advance. So this is the technique of the YNS. So this is the internal jugular vein here. So if you retract laterally here on this vein, so this is the vagus nerve here. So just wrap the lead around here and then finished. So this is a very simple technique, but it is very useful to detect the location of vagus nerve before surgery. So next, I will talk about the focal seizures. And this is a very important concept of fixed zones for epilepsy surgery. And by evaluating these zones, we decided where we should be moved. And these zones are inferior from this kind of stuff. So for example, symptomogenic zone can be inferred from clinical semiology. And for example, seizure zone are inferred from the ictology, and the irritative zone can be inferred from inter-ictology. So we have to evaluate all of these zones, then we predict epileptogenic zone, and we decide where we should be moved. But sometimes this is very, but sometimes we cannot detect epileptogenic zone. So in such case, we need to do the electroimplantation. So intracranial electroimplantation is usually in Japan we did using a subdural grid like this, but this requires craniotomy. But in 2020, FEG, which is the robotic assistant technique, was approved in Japan. It doesn't require the craniotomy because it uses only very, very thin, deep electrodes, so offering much lower invasiveness. So FEG is becoming the mainstream approach in Japan as well. So this is the comparison between the subdural electrode and the FEG, but the most important thing, I think, this is the lower, very, very lower invasiveness. So we usually select FEG for intracranial implantation. But sometimes regionectomy is preferred over FEG, and I listed here. So I show the representative cases. So this is a female patient of 60s, and she experienced a single episode of focal impaired overnight seizure in her life. And the lesion is a cavernous malformation was located in the right posterior thoracic girdle. Her seizure was well controlled with anti-seizure medicine, but significant dizziness and dizziness in this small woman led her to choose surgery. So this is the approach to the inferior form, and I think there are 5 main routes to approach to the inferior form. And first is one tibial approach from above, and one cortical from outside, and from subtemporal approach from below. And this is the anterior approach, and this is the posterior approach. In this case, we selected the supracerebral transcerebral approach from posterior. And this is not me for SCTT approach, and the advantage of this approach is that by incising the cerebral tentorium, you can access the region directly. So this is a very good point of this surgery. So I'll show the surgical movie here. And the position is park bench position like this, and the head is rotating slightly. And this is a preoperative EEG, and this is a postoperative EEG. So abnormal discharge almost disappear after resection. So after craniotomy, you can. So I'll skip the. Sorry. So this is the transverse sinus here, and this is a cerebrum here, and this is the occipital lobe. So we placed subdural grid on the surface of occipital lobe. So sometimes you experience bridging vein between the tentorium and the surface of the cerebellum, but you can cut this vein. And using ICG, we check the tentorial sinus, where tentorial sinus runs, and we cut tentorium, avoiding the tentorial sinus. And this is the surface of parahippocampal gyrus. So then we just try to find the cavernous malformation. Sorry, here's the cavernous malformation, and try to separate the margin, and then finally we remove the regions. And also we use the endoscope, but actually in this case it's not useful. So next I will talk about the case of 5-year-old male patient. And in this case, also this patient was diagnosed with West syndrome, and he experienced neonatal intracranial hemorrhage. But in this case, because mouth screw defect and abnormal cranial suture was detected, so we didn't choose FEG in that case. So in this case, we use CCEP for the monitoring of verbal function. But maybe I don't have enough time, so we just disconnect here to try to the verbal fibers according to the CCEP. And this is the pulse here. So we disconnect temporal and occipital and parietal lobe. So verbal function is almost preserved, and abnormal discharge was almost disappeared after disconnection. So this is a disconnection line here, and he never experienced surgery, seizures after surgery. So also this is a case which was not treated for FEG. This is a female patient in her 10s, and she experienced the seizure from 1 year ago. And she experienced generalized tonic-clonic seizure 1 month ago. And according to CT and MRI, left frontal tumor was identified. So we did resection and awake surgery in this case. So this is the result of cortical stimulation, and she experienced heavy paralysis when we stimulate here. So we thought this is a motor cortex here. And in this area, she experienced normal seizure by cortical stimulation. So we thought this area is responsible for the seizure onset, and we removed here, and she never experienced seizure after surgery. But unfortunately, in this case, tumor growth was observed 2 months later, and the second resection was performed, and the tumor was histologically diagnosed as grade 4 glioblastoma. So when oncological characteristics are uncertain, malignant progression may occur even if not expected. So FPG indication should be carefully considered. So this is the case of FPG. So he's a male patient in his 30s, and his seizure onset was when he was 18 years old. And the MRI shows rare hyperintensity regions in the parietal and occipital lobe, and the hippocampal sclerosis was also detected. But using a scalp EEG, we couldn't detect where the epileptogenic zone, so we did FEG in this case. For FEG techniques, we learned from the New York Hospital, which is a very famous epilepsy center in the world. And the important thing of FEG is most breathing is occurs entry point. So we prioritizing the preventing the bleeding at the entry point, so ensuring the head fixation minimize and discrepancy with planning image. So those are very important for the FEG planning. And we use, this is a robot for FEG, and we don't need craniotomy. So this is a picture after surgery. So we inserted 9 depth electrodes, and 5 contacts are recognized as seizure onset zones. So we did posterior cordon disconnection for this patient. So posterior quadrant disconnection is a surgical technique in which temporal lobe and occipital lobe and posterior parietal lobe was disconnected. And the disconnection line is considered depending on brain function. So in this case, this is the right hemisphere non-dominant. So we disconnected parietal lobe and occipital lobe and temporal lobe, and he never experienced a seizure after surgery, and this study was published recently. So this is a summary, and FEG is a minimally invasive technique that significantly enhance the spatial resolution of the presumed epileptic zones. So this is a very powerful technique, I think. So this is our strategy of laserectomy. So maybe I don't have enough time, and this is an announcement. We are writing now the epilepsy surgery textbook, and we started Instagram. So thank you very much for your attention. Sorry for a long time.
Thank you very much.
Okay.
I'll present Professor Spretzler's video now. Okay.
Yes, please. Okay, Sensei, thank you very much for an excellent talk. We learned a lot. Thank you so much. Raja, we can hear the voice.
I'm going to be talking about intramedullary AVMs,
Can you now?
a fascinating group of lesions. They are depicted here with the extra intradural AVM, the intramedullary AVM that's in the center, the intramedullary AVM that is lateral, and the conus AVM, which is location specific. Extra intradural AVMs cause problems by compression, steal, or hemorrhage. They are previously known as juvenile AVMs, metameric AVM, or type 3 AVM. Here's an example of a young lad, 12 years old, whose symptoms really come from compression. Here you see this AVM that's intradural, extradural in the bone. And here you see the compression as to why the patient is symptomatic. This is the angiogram. This is after embolization. Dr. Albuquerque did a beautiful job. And this is what it is like at surgery. Now here's the AVM. Here you see the intraspinal component of the AVM. And the reason we don't see this, it's just because it's covered with tissue. So here's the intradural component, here's the extradural component. And we're going to go out laterally, always pushing the arteriovenous malformation against the bone, never against the dura, because that spinal cord is already compromised. And as we get control of the AVM, we are going to see whether we can save this nerve root that is surrounded by the AVM. And as it turns out, we're actually capable of saving the AVM. We then go intradural and get the component that's inside the spinal cord. And the post-op, this is the pre-op MRI scan, and you can see how the spinal cord has reopened, and the patient was immediately better because the compression was gone. Conus AVMs are something we defined back in 2002, and they are location specific because they have a unique angioarchitecture of where the posterior spinal arteries go around and connect to the anterior spinal arteries, the only place that it occurs in the spinal cord. They're always located at the conus, and that's why you have both myelopathy and radiculopathy and subarachnoid hemorrhage. Here's an example of a young professor who had a subarachnoid hemorrhage, neurologically intact, but you can see on the MRI scan the lesion right at the bottom of the conus. The angiogram, Dr. McDougall tried to embolize it, but with test injections, the patient became symptomatic. So here we see the lesion, we're taking it off the conus, and then we're going to be dissecting in between the nerve roots until we get complete control of the AVM. And now you can see the nerve roots, and we just go along. We end up cutting the filum terminaling and taking out the lesion altogether. Discharged home on day 4, came back 6 weeks. The urinary symptoms had resolved, and she had no longer any lesion. So the conclusion for conus AVMs that they're unique, that they're best treated with microsurgery and endovascular embolization, and we had very encouraging results, 88% cure, 43% stable, 43 neurologic improvement. All the ambulatory patients remained ambulatory, and 75% of those that were non-ambulatory patients became ambulatory. And finally, when we talk about the management of intramedullary true AVMs, we are dividing them into the central, being fed mainly by the anterior spinal artery, and lateral. These are the ones that are located laterally on the spinal cord. Here's the central one. You can see from the lateral picture, here are the anterior vessels, the AVM and a venous aneurysm. And in the AP, it's exactly in the midline. So we have no option except to go through a posterior approach and then taking great care to keep the spinal cord intact and going around the aneurysm and the AVM, which is anterior. And finally, we're down to the median raphe anteriorly and getting the vessels that are being fed from the anterior spinal artery. And there's the post-op, and she ended up doing very well. One of my earlier lateral AVMs, these are much more common, but you can see how they are causing problems laterally. This is a patient that had an episode of quadriplegia. You can see the effects on the spinal cord. There was no embolization because a challenge test resulted in hemiplegia, but if you look at the midline, you see that the lesion is lateral, and that is what is so important to recognize. So here we are, AVM is lateral, nerve roots coming out. So what we have discovered is that you can cut along an AVM in the spine, cut across the vessels that go into the spinal cord, and not be confronted with uncontrollable hemorrhage. Quite different from inside the brain, where if we cut through the middle of an AVM, we will have uncontrollable bleeding. But here we are going right laterally, preserving everything that we can. And here we are taking the last little bit, and the AVM comes out. ICG is negative, postoperative angiogram is negative, and the patient had no change in the neuroexam. This is the largest one I've treated. A woman that was relegated to a wheelchair because of her progressive myelopathy, and you can see a lesion that really compromises greatly the spinal cord. It's hard to believe that there's any normal spinal cord within this lesion. Dr. Albuquerque did embolization, and this some of the post-embolization film. Here you see the onyx in some of the vessels, and this is what we were confronted to at the time of surgery. Again, the AVM is lateral, the spinal cord is pushed over to the side, and by this time we'd had quite a bit of experience, so we were very comfortable in coagulating the vessels that went into the spinal cord and then cutting them. Bipolar, cut. Bipolar, cut. And always moving the AVM lateral, so we're not putting any additional pressure on the spinal cord. Frequent ICGs to tell us where there are still feeding vessels, where the flow is. But you can see how we're preserving the nerve roots wherever we can, posterior and anterior. Nerve root preserved, nerve root fibers preserved. Until we remove the AVM, you can still see some onyx down below. But notice how we've preserved the normal vascularity. Post-surgery, she was neurologically unchanged. She came back a year later walking into my office. She was absolutely overjoyed. She was one of the most grateful patients that I've ever had the privilege of treating. So what did we learn? These are our first 20 reported cases that we can, despite partial resection, we can cure AVMs. And there was no uncontrolled bleeding from cutting across the arteriovenous malformation. So microsurgery and embolization remain the gold standard for intramedullary AVMs, and recognizing the ability for obliteration without complete resection has important implications for treatment. I thank you all very much for your attention and wish you the very best. Thank you.
Thank you very much. Huisan?
Thank
Thank you, Professor Spessler, for your presentation. And the next speaker will be Professor Suzama Daisuke. He will talk about the basics and progress of neuroendoscopic hematoma evacuation. Professor Daisuke, please.
Yes. Can you hear me?
Yes.
Yeah. Okay. Thank you very much to invite me in this meeting. So, I'll show you
Do you see
now.
that green button?
Okay.
Okay.
Okay. Today, I present you basics and progress of neuroendoscopic hematoma evacuation. So, basic treatment for intracellular hematoma is conservative treatment, drainage, endoscope, and craniotomy. And basic technique for endoscopic hematoma evacuation instruments is navigation system or stereotaxic system and transparent sheath neuroendoscope suction irrigation device. And it is important basic technique is position and approach to the hematoma. Higher Bauer position, vertical trajectory, shallow to deep hematoma, rotational evacuation. It's very important. I'll show you the basic hematoma evacuation movie. Suction with endoscope through transparent sheath and the monopolar coagulation. And sometimes we can use compression hemostasis with irrigation hemostasis. We can stop almost small bleeding with this technique. All of them are basic technique for endoscopic hematoma evacuation. With this basic technique, result of terminal hemorrhage in my 150 cases, removal rate 82%, operation time 72 minutes, major complication is rebleeding 3.3%. And lobar hemorrhage, in my 80 cases, removal rate 82%, operation time 45 minutes. Major complication is rebleeding 3.5%. Endoscopic hematoma evacuation for terminal and lobar hemorrhage are the basic technique because same result compared to craniotomy, same technique compared to craniotomy. And small craniotomy could be made if possible, just in case difficult to stop bleeding. easy to introduce former neurosurgeon. And advanced technique need suction underwater, navigation guided approach, transventricular approach, irrigation and suction control, evacuation using flexible scope, sometimes difficult. And I think this technique is advanced technique. Now, this movie into the thermic hematoma and move to irrigation hemostasis into the thermic hematoma. And the operation moved to intraventricular hematoma from anterior horn. And this technique is flexible scope. And here is foramen of Monroe, evacuate the hematoma. And this is for foramen Monroe, and get into the third ventricle and suction the hematoma. So you can see the aqueduct. With this advanced technique, result of cerebral hemorrhage, my 12 cases is removal rate 85% and operation time 90 minutes. All of them are supinolateral position. And result of thermic hemorrhage, my 50 cases removal rate 70 to 76%, operation time 95 minutes. Minor complication, intraoperative venous injury, 6%. I think advanced technique is needed for cerebral and thermic hemorrhage, difficult to control suction and irrigation, and difficult transventricular orientation. But compared to craniotomy, easy access to a hematoma and short-time hematoma evacuation. And advanced technique, just one case, I evacuate midbrain hematoma through the third ventricle. This technique needs visualization underwater and evacuation and hemostasis. All of these technique do underwater. And we have to approach without navigation. All of hematoma of the midbrain removed, and the patient get better. Progress of endoscopic hematoma evacuation need easy access hematoma and hematoma evacuation technique, and hemostasis and visualization is difficult. And we don't have good surgical tools for this surgery yet. Endoscopic hematoma evacuation for abdomen and lobar hemorrhage is easy under basic technique. For thermic and cerebral hemorrhage, we need advanced technique to visualize and evacuate hematoma. Progress for this surgery depends on surgical skills and surgical tools. Thank you for your attention.
ありがとうございました。素晴らしい役でした。
Thank you, Professor Daisuke.
Yes.
So we move on to the next presentation by Professor Nato Kimura. He will talk about mechanical thrombectomy, established evidence, and the unexplored frontiers. Professor Kimura, please.
Okay, can you see my slides?
Yes,
Very good. Yes.
we can see.
First, I would like to say thank you to Professor Yoko Kato to give me the opportunity to present today. My topics is about the mechanical thrombectomy and established evidence and the unexplored frontiers. So this is my topics today. And first, the evidence. The large vessel occlusion with the anterior circulation is the mandatory treatment for the thrombectomy. Like the right side, this is the right M1 occlusion, and after the thrombectomy, we got a good recognition. And the AHA guideline shows that evidence of A to the within 6 to 16 hours as last known, and the LVO in the anterior circulation. And we also within 24 hours, it's B recommended. And also in the Japanese guideline, it's almost the same. Evidence level A in the 16 hours and the grade B in the 24 hours. How about the large ischemic core? We calculate the ischemic core with the aspects ratio. And the 10 is the maximum, and under 6 is the low aspects. So this paper is from Japan, with the large ischemic core. Aspects 3 to 5, this means that it's already have the big amount of the infarction. From this paper, it shows that from M modifier ranking scale 0 to 3, it's better functional outcome with an endovascular. So it's better to do even if we have the big, large ischemic core. But we have to mention that the more intracranial hemorrhage appears in the endovascular group. And the other two papers had the same conclusion from China and from Europe, that if we add the endovascular treatment with the large ischemic core, we could reach to the good clinical outcome. And how about the posterior circulation with the PC or V or the basilar artery? This is a paper from China, attention study. This shows that even for the posterior circulation within 24 hours, it's better to do the thrombectomy comparing to the control group. And the other two papers also show the same results. Within 24 hours, it's better to do the thrombectomy even for the posterior circulation. Now, how about the strategy? Most of the evidence is by the stent retriever system, but now we have the aspiration catheter like this. We just go through to the occlusion part and we just suction and make the contact aspiration to the clot like this. This is a clot with the suction catheter. This is a first paper from ASTRA trial, shows that contact aspiration is not inferior to the stent retriever system. And also this is a COMPASS trial. This is also has the same result. That the good recognition reached to 91% compared to 89%. And the 90 days of MRS is almost same. So the contact aspiration is non-inferior functional outcome comparing to the stent. So aspiration catheter and the stent retriever system is the same evidence. Now, how about using both stent and aspiration like this? We put the stent on the clot and we give the suction and pull the stent like this. This, now we pull the stent, and the stent will contact like this, and we can catch the clot tightly comparing to each devices. But we only have one RCT from France, combined technique versus stent retriever system. This shows, unfortunately, that the assigned initial intervention alone with that good recognition was combined better, but the final recognition comparing to the stent and the combined technique is no significant difference. And also 3 months and 12 months, there was no significant difference between stent group and the combined group. So this is a selection techniques. The stent retriever and the aspiration, contact aspiration has a high evidence level, but combination technique has a low evidence level. But the recognition rate maybe combination is high, but each other is also high. And we have to think about the cost because the stent retriever is $4,000 and the suction aspiration catheter is $2,800. So if we do the combination, we use both. So it's more than $6,000. This is our hospital strategy. In Japan, all devices are fully covered by insurance, so we didn't care about the cost. So we do in the most of Japan situation, the combined technique is the main technique for the thrombectomy. I'll move to the next. Can we skip the RTPA? The TPA is alteplase is well-known good drug for the very acute stroke stage. And comparing the placebo, the good clinical outcome became twice as much as placebo. But it takes 1 hour to give the drugs. So if we do the thrombectomy faster compared to the giving that RTPA, it may be better. But there are 5 papers. The 2 papers show that the direct thrombectomy is not inferior comparing to the bridging. But 3 papers, it's better to do the TPA, better to doing the AVT alone. So endovascular treatment, IV TPA should be administered when illegal, but do not delay the time for the EVT. So I move to the MEVO. MEVO is the medium vessel occlusion. It's like M2, M3 or the A23 or the P3, P4, the distal part. At first, ELMOS collaboration is a meta-analysis of the big clinical data. This shows that the M2 occlusion may be better to do the endovascular treatment compared to the control group. So EVT should be considered for the M2 occlusion. And this is another paper. This also has the M2 segment. The recognition may be not bad, and it's better to do it, but mentioned for the hemorrhagic complication. So our series, we did that MEVO, a lot of MEVOs. So in our hospital, the 23% was already MEVOs compared to another vessels. So we have a lot of MEVOs. So we did the MEVO with the aspiration catheter. But unfortunately, these days, there became some papers. This one is the Escape MEVO. It's open in 2025. The primary outcome, EVT achieves, routine EVT is not showed benefit comparing to the medical treatment. And also another 2 papers showed the same conclusion that this was also opened in 2025 that did not improve the disability compared to the medical group, and the discount also had the same. So from this point of view, MEVO is not recommended from the papers. How about the low NIHS with LVO? Like this patient had a very low NIHSS, so very slight paresis, but this showed the left ICA occlusion like this. This is a DSA. We did the patient, we had a good outcome, but from the paper, the EVT increases the early neurological deterioration risk in low NIHS MEVO, and the routine EVT for the low NIHS MEVO is not currently supported. So maybe we can think a while if the patient have a benefit or not for the low NIHSS LVO. And this is another paper. This also showed the same results, that endovascular treatment did not improve the functional outcome for the low NHS LVO. So maybe we have to think very a lot about this. And I'll move to the ICAD. We think that we do a lot of thrombectomy, but sometimes we face to the ICAS. This means the occlusion is made by the atherosclerosis case. So when we face to the acute stroke, can we detect this is like this one is a right left MR occlusion? Can we guess this is ICAS, the stenosis, or the non-ICAS, means the embolic event? It is very difficult because the non-ICAS and ICAS, we have the stenosis here. But once we occlude it, both situations seem same during the DSA. But one paper, we have to, it has a chance to detect the ICAD with the imaging, the presence of the calcification of the intercardial arteries. And pre-procedure left meningeal collateral is much more in the ICAD case. The infarct volume is a little bit small in the ICAD case comparing to the thrombectomy, usual embolization. And the presence of the ICAD in another vascular artery shows that maybe it is ICAD, but otherwise it's difficult to detect ICAD. But we cannot detect the ICAD before DSA, so usually we do the DSA, and the result is not bad because intraoperative occlusion is a little bit higher in the ICAD, but the final recognition is not bad compared to the usual non-ICAS cases, and the MR score at the 90 days is not bad in the also same. But we have to mention the punctuative perfusion rate minute is a little bit higher comparing to the non-ICAD case. So I show you one case. This is the previous picture that I showed you. This is left among case. This had a lot of left meningeal cases. This may be a ICAD case. And first we did aspiration. We saw the stenosis at the left M1. So we gave the PT at this part, and we had a good recognition like this. And I'll go to the last topic, the tandem lesion. Tandem lesion is including in the ICAD. We have the neck ICS stenosis and the occlusion in the intercranial. So which should we treat first? The occlusion part or the stenotic part? From the paper, comparing to the retrograde approach or the antegrade approach, the 3 months outcome was better in the retrograde approach. So it's better to do the thrombectomy first, and after that we do the CAS. And this is another paper also shows that the retrograde is better outcome compared to the anterograde. So like this case, this is 70 years old, NHS was 23, and this patient had EC occlusion and neck IC stenosis and IC occlusion. So we navigate the microcatheter, and we do the combined technique with the stent and microcatheter, and we got the good recognition. After that, we move to the neck IC stenosis, and we put the stent like this, and we got the good recognition. So door to puncture was 32 minutes, and puncture to recognition was 32 minutes. It was very fast, but we got the good recognition. And this is a post-operative MRI. We had the MRI had a little bit infarction, but the NHS increased from 23 to 9 in day 7. So this is my conclusion. The thrombectomy to the LVO is mandatory treatment, and the routine EVT is not recommended for the all MEVOs. A low NHS LVO is maybe not recommended. The ICAS is difficult to detect before treatment, but it's better to do it. The retrograde approach may be better for the tandem lesion. Thank you very much.
木村先生、ありがとうございました。Thank you very much.
Thank you, Professor Kimura. We can move to the next presentation by Professor Wataru Suruta. He will present about anatomical flow diversion by hybrid strategy for intractable large cerebral aneurysm. Professor Suruta, please.
Sorry, can you hear me? And can you see my slides?
Yes, we can see the slide.
Okay, thank you. Thank you very much. It's my great honor to make my presentation in this Young Neurosurgeon Symposium. Today's my topic is anatomical flow diversion by hybrid strategy for intractable large cerebral aneurysms. Right, let's see why. Efficacy of flow diverter for non-branching sidewall type aneurysm is apparent. This case, ICA multiple aneurysms were treated by flow diverter, and on 1 year for a angiogram demonstrating complete obliteration of multiple aneurysms and complete reconstruction of ICA. But how about these aneurysms? Bifurcation large aneurysm and branching sidewall large aneurysm, such as fetal become aneurysm. These are very difficult to treat, to be cured by flow diverters. This is a systematic review of flow diverter for bifurcation type. And complete occlusion rate is reported to be 68%, not so high, and very high complication rate of 22%. And this is another systematic review of posterior communicating artery aneurysm. And in this report, complete occlusion rate, especially for fetal PCOM aneurysm, is 42%, very low. So new strategy for these intractable aneurysms is needed. This is our original strategy concept, anatomical flow diversion. And which type of aneurysm is the easiest to be cured by stenting? The answer is non-branching sidewall type aneurysm. So our concept of AFD is transformation from bifurcation type or branching sidewall type to non-branching sidewall type. This slide is showing AFD steps for bifurcation aneurysms. First step is a stent-assisted collateralization. Adequate collateralization and the straightening is very important, straightening of the parent artery by stenting. And when the aneurysm recur, we do transformation to non-branching sidewall type aneurysm. We do additional collateralization as well as right P1 occlusion with coils. And bypass surgery is used in combination for intolerant case to branch occlusion. I'll show you some case of AFD. This is vaginal top large aneurysm. And okay, which branch should we put stent in? The answer depends on development of P1 perforators and PCOM arteries, because we have to preserve P1 dominant side of P1 perforators, and also we have to preserve hypoplastic side of PCOM artery. In this case, P1 perforators is equal development, and left side is hypoplastic of PCOM artery. So I selected vaginal to left P1 stenting. Initial treatment is a simple coiling. but recurrence occurred, so we did stent-assisted polymerization. I put enterprise stent from basilar artery to left P1. However, further recanalization occurs, so we intended anatomical flow diversion. In this case, SCA also included in the aneurysmal neck. So we have to occlude both SCA and P1 orifice. So we did bypass SCA bypass and clipping the branch of SCA orifice. And also we did internal occlusion of P1 orifice with coil, as well as intra-aneurysmal coil embolization. And finally, transformation to non-branching sidewall type aneurysm was achieved. And we can see a complete obliteration is maintained on 36 months follow-up angiogram. And another case, similar case, basilar top giant thrombose aneurysm, thrombose. And P1 perforator is left dominant. And in all cook test, left P-com artery is hypoplastic. So I put basilar 2 left P1 stenting. And this case also SCA was involved. So we did SCA bypass and clipping at the orifice of SCA. And we occlude P1 orifice and as well as aneurysm with coil. And we can see good straightening transformation to non-branching sidewall type and on follow-up angiogram, and complete obliteration is maintained. This is IC top large aneurysm case. Initial treatment was stent-assisted coil embolization with enterprise 2. But recanalization and also aneurysmal enlargement occurred. So we did additional coil embolization and stent in stent with LDIS blue. However, further recanalization occurred, so we planned anatomical flow diversion. In this case, contralateral ACOM cross flow was sufficient, so we could simply occlude left A1. So we did additional coil embolization and intentional A1 occlusion. And non-branching sidewall aneurysm type was completed. And 1 year follow-up, the angiogram demonstrating complete obliteration of the aneurysm. Next, AFD steps for branching type aneurysms, such as fetal PCOM aneurysm. And first step is bypass and debranch, and followed by flow diverter, and sometimes we do stent-assisted polymerization like this. I'll show you one case. Right RCPC, large aneurysm and fetal PCOM arteries arising from aneurysm dome. Very interactable. And right STA PCA bypass and the PCOM clipping was performed. And this is PCA P2 segment and STA PCA bypass is performed and nicely connected. And next, PCOM clipping, and we can see tiny perforator from PCOM, and we clipped clipping of PCOM artery at the orifice and preserving PCOM perforator. This is a postoperative angiogram demonstrating good patency of bypass, STA bypass, and nicely debranched by clip. And 25 days after the bypass surgery, we did flow diverter embolization. This is a long wide neck type, so we put telescopic stenting with flow diverter pipeline. Like this. This is final range or COMBIM CT demonstrating good apposition to vessel wall, and final angiogram demonstrating contrast material stagnation in the annulus. And this is post-operative diffusion MRI, detecting no ischemic complication, and the patient was okay. And 6 months follow-up angiogram demonstrating complete occlusion of annulus, and also we can see good patency of PCOM perforator like this from collateral flow. This is summary of anatomical flow diversion result, and we did 10 cases. And as for location of aneurysms, 6 in basilar artery, and 1 IC top, and 3 ICPC. And the bypass surgery was used in 8 cases. And as for stent, 3 enterprise, 3 flow diverter, 1 uniform mattress, and the combination of Elvis and enterprise in 2, and flow diverter Elvis combination in 1. And the complication was in 1 case, and this is cerebral infarction due to PCOM perforator occlusion. I'll show you later. And complete obliteration of the aneurysm was achieved in all cases. And 2-year follow-up modified ranking scale 0, 1 is achieved in 7/9, and only 1 case has not passed 2 years. Okay, this is complication case. Right ICPC, large aneurysm, very, very wide neck, and fetal PCOM is arising from door. And we did ST bypass and the branch of PCOM artery. And in this case, PCOM perforator is arising fast. Perforator is arising from here, very, very near the orifice of PCOM artery. So it carries risk of perforator occlusion when we clip the PCOM artery. And this is post-operative MRI, POD1. No ischemic complication, and the patient woke up without any deficit. But second day 2, post-operative day 2, she developed mild hemiparesis and left hemiparesis and sensory disturbance. And this is day 7 diffusion MRI demonstrating right thalamic and geniculate body infarction. It means PCOM perforator occlusion. Maybe extended thrombosis after clipping was the cause of this infarction. Mechanism of perforator occlusion after AFD. Mechanism 1, extended thrombosis at stem. And the periprocedural antithrombotic therapy might be useful. And mechanism 2 is a direct occlusion by clipping. So accurate preoperative evaluation of perforator orifice on COMBIM CT, and of course, intraoperative confirmation of preserving perforator is very important. So in conclusion, anatomical flow diversion would be useful for intractable large cerebral aneurysms, especially for bifurcation of branching sidewall type with high curability, while safety verification, especially if for perforator ischemic complication is needed. Thank you very much.
Oh, Susan, thank you very much for it. Please go ahead.
Thank you, Professor Suruta, on the wonderful talk on mechanical thrombectomy. And the next speaker will be Professor Stephen Tandin. He will be talking about thrombectomy for hyperacute ischemic shock.
Thank you so much. Thank you, Professor Kato, for the invitation. I'm so happy can be here. Uh, Actually, I will talk my experience how I starting the neuroendovascular service is in my town, developing country. What is the challenge? Also the future. This is my personal experience. So, in here I'm not like teaching, but I want to share what I do to develop in my country. First, I declare there is no conflict of interest. So, actually, I start in my hometown in Indonesia, in Medan. I start with people who mostly go to the outside for the medical tourism, mostly go to Malaysia and Singapore, and the rest go to Japan, US, Germany, and other country. Uh, why this happened? Because our facility and medical staff, the distribution is not well separate. So mostly concentrate in Java, the main island of Indonesia. So this is the cause many from many citizens from the other island go to another country for having medical tourism. Indonesia is a archipelago country, and most development is on Jakarta. So, from Medan, if I want to go to Jakarta, I need to fly around 2 hours and 15 minutes to 30 minutes. But it's very near if I go to Malaysia, go to Penang only 45 minutes, and go to Singapore only around 1 hours. So it's very near to go to another country. And we have Indonesia have a very huge population, around 277 million people, with only around 500 people a neurosurgeon, and around 300 concentrate in Java Island. If we want to fly from east to west of Indonesia, it need a 10 hours flight. In my prefecture, not Sumatra, my town is Medan. In Medan, we have around 2.5 million population, and our neurosurgeon is 18. And for whole Sumatra, we have 26 neurosurgeon. And for neurointervention, from neurosurgeon, only 3. And the rest is from intervention radiology and also from neurology intervention. I start my neurosurgery training only with open surgery. So when I do my residency, I never exposed to the neuroendovascular treatment. I start my endovascular training at Toyama University, 200 assistant with Koyama Sensei. And then in 233, I went back again with Professor Kimura to learn more about the mechanical thrombectomy. Why I choose mechanical thrombectomy, I will explain in later. So this is the place I work. I work in a private hospital in Siloam Hospital chain that located in Medan. We also have a cath lab, and we are neurosurgeon in Siloam is a team. So we are led by Professor Eka and Professor Julius that located in Jakarta in the Java. I and Michael, we are located in the west part of Indonesia in Medan. We are very happy to join this group because when we have difficult cases or challenging cases, Professor Eka and team will come to help us. This is our neuroscience team in local in Medan, neurology, neurosurgeon, also the radiology intervention. I work together with the radiology intervention. We usually do the surgery together, and this is the challenge. So establish the new interventional facility in low middle income country. The first challenge is lack of knowledge in emergency and also cath lab service. The second one is we also lack of awareness among practicing doctor and public about the neurointervention service. So there is still a lot of doctor and public do not know our hospital can do the neurointervention service. And also previously we have a problem in the chain supply for neurointervention consumable in my town, because mostly the supply is they put it in Jakarta. So if we want to use it, we need to send it from Jakarta. And also high cost of neurointervention consumable in the country, because we are a low middle income, and high cost consumable is also a problem. So what is the solution? So I try to develop what can we do to face this challenge. The first thing is I work together with the neurologists. We teach and train the emergency department about the emergency of for neurological cases, for like stroke, aneurysm rupture, and something like that. And my college radiology intervention will teach the staff in the CAT lab how to make a quick preparation. And then we do the multiple interactive awareness session conducted inside and outside the hospital for the practicing doctor and also public to tell them that now we can do the neurointervention cases. And then for the chain supply, so by time after our case number of case increasing, the company now willing to put their consumable in the hospital. So now this problem is already can be solved. And the main problem is still the cost. So now the treatment is still limited to the private insurance and well-off families for the payment. So for the low-income family, we still try to find what can we do to make this service can achieve a whole society. And the other main problems is actually I will ashamed to say like that, but our main problem is still we still like a lack of trust of the society or citizen to the healthcare professional. By this paper, we still it's stated that still many citizen or people in my country seeking for health care in outside, mostly in Malaysia and also in Singapore. So what the solution that we will do for this kind of problem? First, we focus on in emergency cases. So that's why the second time I went back to Japan, I want to learn more about the mechanical thrombectomy, because for emergency cases, the patient need to be done in Medan. So we try to do the best and give the good result, and then from that result we utilize the local and social media for the education and also successful treatment case to increase the belief and also the confidence of our staff and also the confidence of the society to our hospital. And then we still until now we still do the public education campaign to educate them for emergency cases need to be done quickly. And we also engage the community leaders, religious figure, insurance leader, and also the government to solve the trust issue problem. And we start in November 2023, and until now we have most of our cases mechanical thrombectomy, 21 cases, and for coiling case, and the second one is coiling and also it's catheter and also for angioplasty. So that 3 cases is the most cases we did in my hospital. This is some cases that we have. Like we have a 40 years patient come with right witness with decrease of consciousness 2.5 hours before admission. So our neurologist did the thrombolysis, and we because we know this is a LVO, we directly go to the CAT lab. We see the it's still occluded. So we did the thrombectomy. We still find there is a thin flow from the MCA. So we do the angioplasty with balloon, and then the flow is become better. So this is a tandem occlusion. The patient 90 days recover with MRS 0. This is the second cases. Our skull-base surgeon, he have a big tumor, so he sent to me. We do the embolization for the tumor before the surgery. We have done 2 times, and it give a quite good result. And then for coiling, I have 46 years old come with decrease of consciousness 7 hours before admission. So from the CT angio, we found there is a huge basilar tip aneurysm. We do the coiling. Fortunately, totally occluded, and the patient survived very well with VP-SUN. We also have 69 males with the right witness and also partial aphasia motoric due to recurrent ischemic stroke. So after going to several hospital, then he came to our place. We checked the carotid. We found there's a severe ACA stenosis with ulceration. So after I consult with Kimura Sensei. And we decide to do the carotid artery stenting. We do the CAS. So I with my colleague, Dr. Harley, we do the carotid artery stenting. And fortunately, it's deployed very well, and the patient, and we also have a good result. The patient do not have any attack anymore, and still having the dual antiplatelet for 6 months. And we also fortunately have a very we can say a rare case. So this is a CCF, carotid cavernous fistula, but it's a drain in the pontomesencephaly and cervical cord venous, and it's a delay one. So after 3 months, the patient develop a weakness and hypostasia and also tetraparesis. So the first time we do the MRI, we saw there is edema in the medulla oblongata and cervicothoracic spinal cord, and also we saw a serpentine-like signal void structure suggesting the perimedullary vein enlargement. So we do the DSA, and then we found there is a CCF that drain to the posterior, drain to the superpetrosus and also inferior petrosal sinus and perimedullary vein. We search the literature. We found that this is the 7 cases reported in the world. For this case, we use first we use a balloon detachable. After we detach the balloon, we still found that there is a flow to the back. So then we do the coiling to close the posterior part of the balloon, and fortunately it's totally closed, and the CCF is gone. But unfortunately, for this patient, the patient improved very good. The deep node is gone, and then the muscle strength is become much better, and the patient can walk again in 1 month. But the MRI in the first and 6 months showed the recovery in the spinal cord edema, but the patient still have a 6 nerve palsy. It's been around 2 years, and it's still there. The 6 nerve palsy is still there. In our opinion, this maybe this caused by the compression of the coil and balloon to the 6 nerve, because the palsy is still permanently there. I'm so happy I'm part of a Koyama Sensei. I'm so I'm so I'm so happy to meet these all people that show in the slide. Without these people, I cannot develop a neuroendovascular treatment in my hometown. I believe that my presentation it will not occur in a developing country, but in developed country, but in developing country, I think we still have the same problem like in Thailand, Vietnam, maybe in Africa, we still have the same problem. I hope that my experience can be take to develop the endovascular treatment in the young neurosurgeon hometown or country. Thank you very much for the opportunity.
Thank you, Professor Tandin, for your wonderful talk. Next, I would like to invite Professor Miki Fujimuta. He will be talking about ECIC bypass, standard surgical procedure, and the tips for complication avoidance.
Okay, and thank you for the kind introduction. So first of all, I would like to thank Professor Yoko Kato for giving me this opportunity. So my topic is about ECIC bypass. I focus on the standard surgical procedure and tips for complication avoidance. I have no conflict of interest. So this slide shows the current guideline recommendation of the flow augmentation STMCA anastomosis. Of course, the best indication for that for moya disease, but we also indicate the STMCA bypass for the atherosclerotic occlusive disease if the patient is satisfied all of these criteria. If the patient are symptomatic and if they satisfy the hemodynamic compromise criteria summarized in this slide, we definitely indicate bypass surgery for this kind of atherosclerotic patient. This recommendation is based on the result of JET study conducted in Japan. I would show only one case of the atherosclerotic patient. He had the left ICA occlusion presenting with the minor stroke on the left hemisphere. And important point is in the chronic state, he had a definite hemodynamic compromise as shown by the SPECT. And he had a remarkable reduction of CBF on the left hemisphere, and also the cerebral vascular reactivity is significantly decreased. So in such patient, we indicate the bypass surgery, and the patient did well after surgery. But everyone knows the best indication of pro-augmentation bypass these days is for moya disease. This is the most recent guideline of moya disease, and surgical revascularization is considered reasonable for moya disease with ischemic symptom, and STMCA bypass is a gold standard especially for the adult patient. So the question is, what about for the hemorrhagic onset patient? These days, we already know the result of Japan adult moya trial, which is a randomized control trial to examine whether the bypass can reduce the risk of rebleeding in hemorrhagic onset patient. And the initial paper of the JAM trial show the result was much better in the surgical case compared to that of the non-surgical case. And the second paper of JAM trials has a striking result. And if the hemorrhage is located as the posterior circulation territory, and the patient has a great benefit from the bypass. The non-surgical case has a 17% annual rebleeding risk, but if they underwent surgery, result was much better. So most recent guideline recommend the bypass surgery for the hemorrhagic onset moya disease patient, especially for the patient with posterior hemorrhage, based on the result of Japan adult moya trial. So based on them, I will talk about the cases today. And this is a representative case. She's a little bit old case of the moya disease, but she presented with the intraventricular hemorrhage, as shown in this slide. And the MRA showed the suggested moya disease, and the T2 star weighted imaging indicated the hemorrhage was located at the right thalamus, the posterior hemorrhage. This is the catheter angiography before surgery. And important point of this slide is the patient had the remarkable transdural collateral circulation from the external carotid injection. And this is the middle meningeal artery connected to the intracranial vessels. And she had a multiple transdural anastomosis. So during surgery, it's very important to preserve all of these pre-existing collaterals during craniotomy or dural incision. So anyway, we believe that she had the definite indication for the bypass. And well, fortunately, she had a good donor artery here, the parietal branch of the STA. So we indicated bypass surgery for her. And she also had the hemodynamic compromise on the right hemisphere. So we recommend combined revascularization for this particular patient. So again, I attempted to preserve the remarkable transdural collateral. So I made a little bit smaller craniotomy, avoiding this pathway of the collateral. So this is a short video. I made a cut down procedure. I mean the skin incision along with the parietal branch of superficial temporal artery, which is not so thick in this patient. And after this, we make a craniotomy. But during that, I keep the temporal muscle flap for the indirect bypass procedure. This is a temporal muscle flap, which would be used for the combined surgery. And after the 3-bar hole, I make a dural incision. So on the brain surface, fortunately, this patient had one candidate of the recipient artery. The diameter, vessel diameter is as big as 0.89 millimeter. But important point is the vessel wall structure of the recipient artery is very weak, very thin vessel wall. But on the other hand, the donor artery has a little bit thicker vessel wall because she is 60 years old. Real atherosclerotic donor vessel wall, and the recipient vessel wall is very thin, which is called a negative remodeling, which is a characteristic of moyamoya disease patient. So we use the pyoctanin dye to stain the adventitia to recognize the vessel wall layer. And even for such a hemorrhagic patient, I loaded the aspirin 2 weeks before surgery, and I put 4 stitches on one side and wash it with a heparin saline and make a ligation together. So during the 20 minutes temporary occlusion time, I completed the end-to-side anastomosis in this patient. So Doppler spirometer works well, and also the IC green video angiography showed a favorable bypass flow in this patient. And after this, I combined the indirect procedure, encephalodural myosyngiosis. And then I put the bone flap. And I also use the bioabsorbable plate in this, only in this site for the aesthetic reason. So the patient was well after surgery, and here is a bypass flow recognized by the MRA, and she didn't show any neurologic deficit after surgery. So this was the procedure, standard procedure of the STMC anastomosis. And the next step, I would show another case. This is a little tricky case. This patient already underwent a bilateral STMC anastomosis, but after a lengthy of follow-up time, she had a progression of the PCA stenosis and occlusion, and ultimately showed the hemodynamic compromise on the right occipital lobe. And she became symptomatic, which means she had a transient ischemic attack even after the anterior bypass. So we decided to make additional salvage surgery or OA-PCA anastomosis for her. I think this is OA-PCA bypass is a very useful procedure for such patient for the recurrent TIA even after the anterior bypass. The slide shows the position. I make a park bench position, and the important point is I use a spinal drainage for this patient. You will know the reason later. And I make a cut down procedure, skin incision along the occipital artery and extend it to the anteriorly and make such craniotomy. So this is my standard procedure of OA-PCA bypass. Again, I make a skin incision over the occipital artery. And here is again the negative remodeling of the recipient artery, which means the vessel wall is very thin in patient with moyamoya disease. And after the completion of the OA-PCA bypass, I make a combination of indirect bypass for her in a similar way. So I think the final surgical view is very similar to the STMCA bypass, but sometimes it's very effective procedure. So in this patient, her transient ischemic attack completely disappeared after surgery. And this is the single photon emission CT in the early acute stage after surgery. And you will see the remarkable CBF improvement at the site of the anastomosis. And the OA-PCA bypass is recognized as a strong high signal as shown by the postoperative MRA. So I think this procedure is very important because many patients conduct anterior bypass first, but some patients show the progression of PCA later. And if they become symptomatic, I think OA-PCA bypass has the best indication for such kind of recurrent ischemic symptom. So in the last of my talk, I would talk about the perioperative management. This is also very important, especially in moyamoya disease. It's very important to avoid the ischemic complication during surgery or after surgery, of course. But I would like to emphasize the local hyperperfusion. Too much blood flow after bypass surgery is very important, and we should avoid the symptomatic hyperperfusion after the bypass for adult moyamoya disease, especially. So my initial series apparently show the symptomatic hyperperfusion is much more common in moyamoya disease compared to atherosclerotic patient. Such kind of local hyperperfusion immediately after surgery is not very rare especially in adult moyamoya disease patient. And in very rare occasion, such kind of local hyperperfusion could result in the delayed intracellular hemorrhage, which is one of the most deleterious complication of the ECIC bypass for moyamoya disease. So it's very important to avoid such kind of deleterious results. So I would talk about how to avoid such a complication. So 20 years ago, it was blood pressure lowering was contraindicated in moyamoya disease surgery. But recently, we know that a mild blood pressure lowering can reduce the risk of local symptomatic hyperperfusion in moyamoya disease. So this is my perioperative protocol. We conducted a mild blood pressure lowering with the anti-inflammatory antibiotics, and we routinely perform the single photon emission CT 1 and 7 days after surgery. So, but still, it's very difficult to predict the hyperperfusion in individual patients. So, in the last 5 minutes, I would talk about the very interesting IC green video angiography study in terms of the prediction of hyperperfusion. I would begin with this very straightforward patient. She had either ischemic onset moyamoya disease, 40 years old woman, and everyone knows she has the definite indication of bypass. So I attempted the combined revascularization in this patient. But during surgery, I recognize this is the only one candidate of the recipient vessel artery, but the next of this side, the vessel shows a remarkable negative remodeling, almost occluded. But anyway, I completed the successful bypass to this site. But I was so scared because this site was very stenotic. So I keep watching under the IC green filter for a couple of minutes, 3 minutes, 4 minutes. So 3 minutes later, after the injection, ICG injection, I recognize a remarkable extravasation of the ICG dye in this site. But under microscope, there is no difference, no difference. What happened to this patient was she had a remarkable pathogenic edema at the corresponding site. So I got the idea that late phase IC green angiography could be useful to predict this kind of pathogenic edema or hyperemia after bypass surgery. So after this patient, I conducted the serial IC green study. Injection is only one time, but I observed the ICG not only at the early phase to recognize the bypass, but also the late phase observation, 3 or 4 minutes after the injection of ICG, and observed very carefully over the brain surface around the site of the anastomosis. So I got a very striking result of this 50 cases study. So this is a very straightforward case, and the brain surface looks very, very peaceful. I mean, not a remarkable change, but I attempted a very standard IST-MCA bypass, and brain surface looks very, very normal, and the bypass flow is very good. And I didn't expect anything happen in this patient, but during the study, I also watch it 3 or 5 minutes after the ICG injection routinely. What I found was there is an extravasation of ICG around the site of the anastomosis. Yes, this is but the brain surface is very normal. So what happened to this patient was, anyway, this patient has extravasation, so I make an intensive perioperative care. But at 1 week after surgery, she had the hyperperfusion, and here is a pathogenic edema at the corresponding anatomical location of the extravasation. So I make a serial late phase ICG green study, and I observed the ICG green extravasation in 18%. It was not very rare. And statistically, the cortical ICG green extravasation significantly correlate with cerebral hyperperfusion syndrome or local pathogenic edema. So I think this procedure can be the one of the choice for predicting the cerebral hyperperfusion or hyperemia after bypass surgery for myelinating. So I would like to conclude my talk on this slide, and STMCA bypass or OAPCA bypass are reasonable management choice for the symptomatic Moema disease. Preservation of pre-existing transdural collaterals and understanding of intrinsic vascular fragility in Moema disease are essential during surgery. And surgical complications such as local hyperperfusion and cerebral ischemia should be avoided by intensive perioperative care. And our study showed that the late phase IC green video angiography could be useful to predict hyperperfusion or pathogenic edema in Moema disease. So thank you again for this opportunity.
Thank you, Professor Fujimura, for your talk. We can move on to Professor Mehmet Chiali. He will be talking about how to avoid complication of adult deformities surgery. Professor Chiali, are you online?
Maybe we
You
can
can
move
share
to
your
the next
screen.
one. Maybe we can move to the next one, please.
Oh. And now I would like to invite Professor Arthur Annam. He will be talking about global neuro-oncology, lesson learned from Pakistan brain tumor epidemiological study.
He is not
Sorry,
here.
I'm
Limit Sally.
reconnected.
Okay, Sally. Hi, how are you? Thank you very
I
much.
don't see Atarinam here.
Oh.
Good. So we met Sally. Now he's with us now.
Yeah. So Professor Giali, you can share the screen.
Yes, I thank Professor Yoko Kato and the organizers for this very nice meeting. I'm sharing my screen. Okay. Do you see my screen?
Not yet, Professor.
Really? Yeah. Now, is it okay?
Not yet. It's loading. Yeah, now I can see the screen.
Yeah. Okay. My topic will be on how to avoid complications of adult deformity surgery. Actually, normal neurosurgeons are not keen for doing deformity surgeries. However,
Mehmet, sorry.
if
Mehmet.
yes,
Sorry, please.
yes,
Okay. Okay, fine.
yeah. This is a complex thing, deformity surgery. And there are mainly three types of deformity. One is the adolescent idiopathic scoliosis, which happens in children, adolescent ages. They have no comorbidities, healthy spine, and they have very high tolerance to surgery. Congenital deformity is with neurologic deficits and rigid deformity. However, adolescent is flexible, and adult spine deformity in the elderly, they have additional pain and neurology, osteoporotic spine, mostly rigid deformity, and many comorbidities. In one stage, you can think about that aging is being kyphotic, and then spine surgeons are ready to correct that complication of aging, being kyphotic, by changing it with some surgeries. If you look at the complications, adult idiopathic scoliosis complication is about 5 to 15%. It's quite less. However, in adult spinal deformity, there are many reasons of complications: mechanical failure, instrument failure, pseudoarthrosis, adjacent segment disease, systemic complications because they have premorbid diseases, and complication rate may reach up to 45%. Besides, reoperation rate in those adult deformities can reach up to 36%, which the reasons are pseudoarthrosis repair, need to lengthen the fusion, and adjacent level disease requiring decompression. One concern is whether we should add L5S1 level to our surgery, and we must try to avoid it. Otherwise, the pseudoarthrosis rate at this level is quite high. If we want to add it, we must add one extra fixation point to decrease the pseudoarthrosis, and the better is to add iliac fixation to S1 in case of long fixation with L5 S1 level. But the problem may not end with at that point, and sacral insufficiency fractures may happen. It's another type of adjacent level disease, and these can be treated by conservative or surgical measures. Premorbid diseases are also important, and if there is a major systemic disease like cardiac problems, coronary artery disease, or some others, kidney problems, our aim must be to diminish the problem at the most painful area, maybe just short fixations or without a fixation, just at the compressive surgery. To decrease the bleeding, MIS surgeries are recommended. They have less complication rates than the open surgery. However, if SVA is more than 100 millimeters, if more lordosis correction is necessary, and if osteotomy is necessary, MIS techniques are not preferred by many surgeons. There are mainly two surgical techniques to correct geriatric deformities. One is the interbody cage and graft. The other one is osteotomy. And osteotomy complications are quite higher. These are the types of osteotomies. Mainly we use whether a posterior osteotomy or just pedicle subtraction osteotomy. And if the osteotomy type is 4, 5, and 6, then we need to place a vertebral body cage in between the vertebral bodies. This I will skip these slides, but in posterior osteotomies we can achieve 10 to 15 degree reduction in each level. Because of that, 2, 3, 4, 5 level posterior osteotomy is necessary to correct rigid deformity. However, in pedicle subtraction osteotomy, in each level we can provide 30 to 35 degree reduction. The pedicle subtraction osteotomy complications are more high in thoracic levels, especially neurologic complications. Blood loss is high. Dural kinking is a concern, and we must always monitor intraoperatively the patient to decrease the neurologic complications. These are some complications of the osteotomies, and it is an average blood loss in pedicle subtraction osteotomy is about 1,500 milliliters. This series collects 400, more than 400 cases with osteotomy, and total major complication is 42%. If the age is higher, and two osteotomies and thoracic osteotomy, the risks are higher. This is from Lancaster department with overall complication rate is 49%. In 3-column osteotomy, they call the blood loss is more than 2,000 milliliters, and neurodeficits is about 10%. It's quite high. And this series has done only posterior osteotomy, Schwab type 1 and 2 osteotomies. Complication rate is about 28%, and although type 1 and 2, very high complication rate. And this study says that the sagittal deformity angle is more important than the type of osteotomy or surgery. So then the angulation, if the angulation is very high, so we may expect more complications from surgery. And lower osteotomy is preferred, L3 or lower, to prevent complications. And osteoporosis scores are very important to prevent mechanical failures. This study has looked at the surgeon's experience. If it is in the experienced hands, it's total complication rate is 28%. However, in unexperienced hands, it's 44%. And it's more remarkable that neurologic deficit is 4% only in the experienced hands. However, 22% in unexperienced hands. Buckling of a dura is a concern. This is a good operative view. You can see the dural buckling, but if it is too severe, the spinal cord will be also compressed, and we will expect neurologic complications. To prevent this, laminectomy may be enlarged, and we must be aware of that complication. Postoperative dysesthesia is another concern in the lower extremities. This case has developed a postoperative dysesthesia after significant correction of the deformity with very high level of sharp kyphosis. If you look at the results, patient satisfactions are lower if there is a wound infection, coronal imbalance, and poor family or social support. Patient motivation is very important. Frailty of the patient is a big concern. In cases of very frail patients, preoperative rehabilitation must be started, and we must have concerns against delirium and psychiatric disorders after such surgeries. This series tell that if SVA is less than 8 centimeters, results are better. In general saying, geriatric spine surgery, it is possible to change it back to provide a less kyphotic posture in the elderly with a good planning and with a good patient selection. These are the recommendations for adult deformity complications, and this may be a take-home message. We must prepare elderly with ERAS protocols and caution against delirium, and we must try to less bleeding. Otherwise, intraoperative complications are quite higher. These are, I think I can finish my talk here, and I want to promote you to look at the WFNS Education Committee website. We are also making many webinars, and all the recordings are there on the website, and also spine-related webinars are there. You can watch them there. Thank you. Thank you for listening to me.
Thank you, Professor Mehmet. I think Professor Arthur Enam and Professor Rahul Rai are not here online, so we can move on to the next presentation. Professor Mirko Oka, he will be talking about new stereotactic radiotherapy for recurrent malignant glioma.
Sorry, please wait. Can you see my slide and here?
Yes.
Excuse
we
me.
can.
Yes, thank you.
Please.
I'd like to thank for the opportunity to give this presentation today. My name is Miko Okura. I'm a neurosurgeon at Tokyo Human Medical University. Today, I would like to talk about a new treatment for recurrent gliomas. The new treatment is a protocol using fractionated gamma knife radiosurgery. These are previous efforts on high-grade gliomas. At first, using SLT, this paper showed CyberKnife and the overall survival after treatment for patients with high-grade gliomas IDH wild type was 10 months. And second line, patient with diffuse midline gliomas survived for less than 12 months after diagnosis. These conclusions suggested that patients with high-grade gliomas are likely to die within 1 year of recurrence. This picture shows the gamma-knife icon system. Our hospital introduced this system in 2022. Mask exchange is possible, and fractionated radiotherapy is also possible. I will show the detail of the new treatments. At first, at the time of recurrence, rule out should enlargement or radiation necrosis using methionine PET, and so on. Imaging is contrast-enhanced MRI on the day treatment started. At target is T1 gadolinium-enhanced region or FLAIR region. And radiation dose is 30 gray to limbus in 3 fractions. And we use mass bevacizumab. And these are the results according to the treatments administered at the time of the first recurrence. The patients, all of them is GBM. The blue line is treatment with fractionated gamma knife groups. There are 22 patients, and the green line shows the treatment with tumor removal. And orange line shows the treatment with other radiotherapies, CyberKnife, Liniac, and Zapex. The red line shows the treatment with bevacizumab only. The new treatment has the best median overall survival of 16 months. The next slide show, the slide shown earlier was only for the first recurrence, and at this point, all cases were covered. In this case, patient with CBM IDH wild type. The blue line shows the treatment with fractionated gamma knife radiosurgery, and there are 40 patients. And red line shows the treatment involving surgery, bevacizumab, CyberKnife, Liniac, and Zapex, and combination of these, there are 52 patients. The median overall survival after treatment, the fractionated gamma knife group was 60 months, compared with 8 months in other groups. This shows the survival in gamma knife group was twice as long. Next, All patients was GBM2. The blue line shows treatment with fractionated gamma knife, and red line shows the treatment with other. The median progression-free survival in the fractionated gamma knife group was 6 months, compared with 4 months in the other groups. Next, patient with diffuse midline gliomas. The blue line shows treatment with fractionated gamma knife radiosurgery. There are 7 patients. And the red line shows the treatment involves surgery, bevacizumab, cyberknife, and combination of these. There are 11 patients. The median overall survival after treatment in the fraction gamma knife group was 30 months compared with 7 months in other groups. This shows that survival in the gamma knife group was 4 times as long. Next is diffuse gliomas 2. The blue line shows the treatment with fractionated gamma knife radiosurgery, and red line shows the other. The median progress-free survival in the fractionated gamma knife group was 5 months compared with 4 months in other groups. Next, there are overall survival after diagnosis. This side is GBM, and this side is diffuse midline gliomas. The blue line shows the treatment with a fractionated gamma knife radiosurgery, and red line shows the treatment with other. The new treatment groups also shows the increased overall survival rate. I'll present some patient background information. First, the patient with a KPS score 80 or higher before treatment. The gamma knife group is only 17%. And the patient with distant metastasis before treatment, the gamma knife group is 67%. And the patient with ages 50 or under before treatment, the gamma knife group is 27%. And the patient with deep white matter lesion before treatment, the gamma knife group is 87%. And KPS, no change or improvement 6 months after treatment. Gamma knife group is 77%. The gamma knife group has a higher proportion of patients with poor prognostic factors. Post-treatment complications were examined. I checked for these complications, but no difference in safety was observed between the new treatment and other treatments. I think that improvement in outcome is due to the intervention in cases that would previously have been judged untreatable. One patient, a mother with young children, she was diagnosed that made surgery and stereotactic radiotherapy difficult at other hospital. She presented with slides, hemiplegia, sensory loss, aphasia, visual field loss, and headache. I tried to treat all lesions, including the brainstem, at 2 stages. This is before treatment and after treatment. The treatment was effective, improving her condition so that she could walk again. And as of 7 months after treatment, there are no complications. Even when other treatments are ineffective, fractionated gamma knife radiosurgery can still be effective. One case is the patient has glioblastoma, IDH wild type, and she was treated with bevacizumab, but the tumor was resistant to treatment and continued to grow. Since recurrence of confirmed using methionine PET, and the new gamma knife treatment was performed. And 1 month after the new treatment, the tumor had shrunk. And next, the patient has a GBM IDH2. She was treated with CyberKnife and bevacizumab, but the tumor was resistant to treatment and continued to grow. So we checked methionine PET, and the new gamma knife treatment was performed. 2 months after the treatment, the tumor had shrunk. The patient has diffuse midline gliomas. She was treated with ZAP-X and bevacizumab, but the tumor was resistant to treatment and continued to grow. She finally decided to have surgery, but only 1 month after surgery, distant metastases were appeared. The new gamma knife treatment was performed and 2 months after the new treatment, the tumor was shrunk and no complication there. The new treatment can also improve symptoms. The patient had a diffuse midline glioma. The primary lesion was the right thalamus. This time there was a distant lesion with lesion appearing in the parietal lobe. And the patient developed resistance to bevacizumab. He was unable to walk due to left hemisphere and sensory loss. But after treatment, he was able to walk independently. Next patient, the patient has astrocytoma grade 3 IDH mutation type. The primary lesion was the right frontal lobe to insula gyrus. This time there was a distant recurrence with lesion appearing in the cerebrum. He had vomited repeatedly, and he was unable to eat anything and become bedridden. But after treatment, he was able to walk independently. Today, I introduced a new treatment using the gamma knife. And this treatment has a potential to significantly improve the prognosis and quality of life for patients with high-grade gliomas. I'd like to express my deepest gratitude to everyone who stayed to hear the end of my presentation. Thank you.
Thank you, Professor Miyako Oka, for the nice presentation. Now I would like to invite our discussions for the webinar today to have some comments or questions. The discussion of our webinar today, we have Dr. Savannah Biswas from Bangladesh, Dr. Liu from Malaysia, and Dr. Atik Islam. Dr. Liu, do you have any question or comment?
Yeah, no question from me. Thanks.
Professor Tariq Khan, could you give some comment or question?
Yeah, thanks so much. Really excellent talks on epilepsy, thrombectomy, and spinal surgery as well. I just want to add a little comment on our Indonesian colleague regarding development of endovascular management treatment stroke in Indonesia. I had recent meeting, good fortune to meet the Indonesian health minister, and he is very, very passionate about stroke management in Indonesia, and they have developed an amazing program how to introduce training and cath labs across Indonesia so that everybody can have be able to reach a stroke unit within a stipulated period. This program is actually being headed by neurosurgeons, which is a very, very good thing to do. So I just wanted to make aware our Indonesian colleague regarding this program. I'm sure he is well aware of it. I would wish that this program could be replicated in the rest of the lower income countries as well, whenever that is possible. Thank you.
Miyako Sensei, can you hear? Thank you very much for a wonderful talk.
Could you unmute Professor
Please
Kata?
unmute your mic.
Sorry. So I think the gamma knife is one of the future less invasive treatment, and especially your center is a top runner in Japan, I think, in the world, I think. Thank you so much. So what about the effectiveness of the cavernoma radiosurgery? Is it effective? Because there's so many cavernomas located in the brainstem.
Cavernoma is other active case reports. So I think not best radiation dose and best timing is not occurs that now. So future best dose or best timing is corrective. So I think cavernoma is more effective case became.
Okay, thank you. That's wonderful. Maybe the timing and also the dose that you can check. Then you can give the radiation for the patient. That's good news. Thank you so much. An excellent talk. Congratulations.
Dr. Sam,
Hi. Thank you so much for all the excellent lectures and talks. I learned a lot from it. My question is to Prof. Memezaleti. Could I ask on your opinion? You mentioned just now about L5S1 and extending instrumentation to that level. How do you decide when do you cross the L5S1 junction, and when would you put a S2 screw or a iliac screw? How do you make your decisions? Thank you.
Yeah. Thank you for this very nice question. Actually, if there is a significant degeneration at the L5S1, there is laminectomy at that level. And if there is a very long fixation going up to the L1, then you must add L5S1 to your fixation. Because otherwise you will expect too much L5S1 or distal junctional failure. And about adding S2 screw, it is possible, but there are biomechanical studies that iliac screws add more strength to your construct than S2 screws only. Is it answer to your questions?
Right. Okay. Thank you. Then when do you normally extend up to T10 level? Let's say if you were to go up to L1, or because it's another
Up to
junctional level
L1.
at T12 L1. Yeah.
Yeah. Actually, many surgeons believe that we must not stop at junctional levels. We must not stop at the apex of the deformity. So there are some rules like this. So because of that, if you are making a long fixation, to decrease the distal junctional failure, you must add L5S1 fusion. And always you must also add an interbody fusion at L5S1. Not only iliac screws, S1, very nice S1 screw, but also L5S1 interbody graft and cages.
I see. Okay. Not only posterior lateral fusion. So it fuse the body as well. Well, okay.
It is almost a must, an obligation to make an interbody fusion at that level, because non-union rate is very high. Even in good hands, it may be about 20% in good hands.
Oh, that's very high. Yeah.
Yeah, very high.
Thank you so much for the answer. It helps. Thank you.
So, Stephen, you received Dr. Tariq comment. Dr. Stephen?
Yes, Prof. Thank you so much, Prof. Tari. And we are very happy to have you last month in Surabaya for the meeting. Yes, now our Minister of Health is very concerned in the brain and heart, especially for the emergency cases, Prof. So she provides so many cath lab from the west to the east, and now we are also be push and promote to do the fellowship in endovascular for minimal invasive in brain, also for the cardiology. So many of our colleagues of cardiology also sent to the abroad to study. Actually, in a public hospital, it's not an issue, Prof. What I mean, because the government will pay for the citizen that need the help, but still, what I mean, we still because the price is very expensive. It's still a big burden for the country. So as a private hospital, we also want to take part to help our country to less the burden. So for the private insurance, also for the people with well-off families, we can help them to take the emergency cases to reduce the morbidity and mortality. Yes, we are now initiating, Prof. I hope I hope this will be continue and can reduce the stroke, either ischemic and hemorrhage in the world, because we can see in the world map, Indonesia is still a red flag for the stroke prevalency. Thank you very much, Prof, for your support. Thank you so much.
Thank you. I also would like to add, for the benefit of everybody, that Indonesia and Pakistan are now co-sponsoring a resolution with the World Health Assembly to make traumatic brain injury a notifiable and chronic condition. And we hope that this resolution will be put to the World Health Assembly in coming May 2026. Thank you for the support.
Thank you so much, Prof.
Yeah, another copy.
Thank you, Professor. I think Professor Kazunori Shibamoto is not on the webinar at the moment, so we can go to the next presentation by Professor Feng Shu on the artery percurrent infection following surgical clipping of multiple intracranial aneurysm. Professor Feng Shu sent us the recorded video of his presentation. So Raja, could you play the video?
Sorry, is it Xu Feng's video?
Yeah.
Okay,
Ben,
okay,
could you have?
I will play now. I will play now. Can you see the video?
Yes.
Okay.
Good afternoon. Thank you for the invitation. I'm Feng Xu, Department of Neurosurgery from Huashan Hospital, Fudan University. I'm here to share a rare complication, the arterial percurrent infection following surgical clipping of multiple intracranial aneurysms. This is the case description. The 59-year-old female, the chief complaint, recurrent dizziness for more than 6 weeks, accompanied by diplopia. The MR image demonstrated minor ischemia lacunar lesions in the bilateral frontal and parietal lobes. The head CT demonstrated the hyperplasia of the left vertebral artery. No obvious stenosis of the right vertebral artery or basilar artery, but the multiple intracranial sacral aneurysm was detected. The DSC demonstrates the ACOM aneurysm and the right MC bifurcation aneurysm. After receiving the dual antiplatelet therapy, the patient didn't experience any further posterior circulation TIA. Considering the increased risk of aneurysm rupture, we opted to first address the multiple intracranial aneurysm using one-stage clipping. So 1 week after discontinuing clopidogrel, the patient underwent a right supraorbital lateral approach for clipping of the multiple intracranial aneurysms. The intraoperative photos showed the perpendicular clipping of the right MCA bifurcation aneurysm and multiple clipping of the ACOM aneurysm. The ICG confirms the complete obliteration of the two aneurysms and the patency of the parental artery. Post-operatively, the patient regained consciousness with normal neurological function, but 12 hours later, the patient experienced a sudden onset of loss of consciousness. The extremities localized to pain stimulus. Bilateral Babinski sign were positive. So we performed an emergency no contrast head CT. Scan revealed no acute hemorrhage or infection. We also performed the one stage, the CTA showed no large vessel occlusion, and the CTP indicates no definitive core infarction or hyperperfusion zones. 24 hours later, the DWI image showed the high signal intensity, the V side in the bilateral paramedial thalami, with corresponding decreased apparent diffusion coefficient to ADC values. Due to contradictions for thrombolysis following multiple intracranial aneurysm clipping, the intravenous tibrofenib was administered. The patient was treated with intubation, mechanical ventilation, vasospasm prophylaxis, and neuroprotections. After the discharge, the patient was alert with partial memory impairment and normal muscle strength in the limbs. And the bilateral Babinski sign were positive. So 1 year later, the patient was administered again. The follow-up angiographic and demonstrated no residual or recurrence of the two aneurysms. And the right vertebral artery angiogram showed the hyperplasia of the right P1. So the thalamus was primarily divided into 4 areas: the anterior and the posterior paramedial and the inferior lateral region. So here is photos showing the blood supply to the thalamus and the lateral view and the dorsal view. The thalamic paramedial artery, also known as the thalamic perforating artery, have 4 main anatomic types. The type 1 is each perforating artery arises from the respective P1. The type A2, the perforating arteries arise directly from the proximal segment of one of the P1. The type 2B, the bilateral perforating thalamic arteries arise from a single arterial trunk. It's called the artery of the petrous artery. The type 3, the several small perforating branches arise from a single artery that bridges the P1 segment of the both PCA. Oh, the AOP function had very many clinical manifestations. The varying included the varying degrees of the altered level of the consciousness, the oculomotor disturbances, including the vertical gaze palsy, oculomotor nerve palsy, pseudoadenous nerve palsy, and pupillary changes. Additional symptoms included the memory impairment, behavioral changes, motor disturbances, thalamic damaging, and mutism. An MRI imaging, the infarct patterns also was divided into 4 types. So here is the 4 types of the infarction. The type 2 is the bilateral paramedian thalamic infarction without the midbrain involvement. So our case belongs to the type 1. Type 2 is the bilateral paramedian thalamic with the midbrain infarction. And type 3 is the bilateral paramedian and anterior thalamic infarction without the midbrain involvement. And type 4 is the bilateral paramedian and anterior thalamic infarction also with the midbrain infarction. So the treatment in the previous studies has shown the super selective intra-arterial thrombolysis of the pulmonary artery resulted in the favorable neurological outcome. Here is the DSA demonstration, the super selective, the angiography of the pulmonary artery, and this patient, the preoperative angiograph showed the unilateral complete fetal PCA on the right side and a hyperplasia of the left vertebral artery. So we can see the arrow indicates maybe the potential, the thalamic perforating artery, maybe the AOP. So conclusions, for patients with multiple intracranial aneurysm concomitant with vertebral basilar TIA, it is important to be vigilant about the possibility of the posterior circulation perforating artery infarction following clipping. For patients presenting with altered consciousness, vertical gaze pause, and memory impairment, if the MRI reveals infarction in the bilateral paramedian thalamic region, the V sign, so the AOP infarction should be considered first. Raising awareness of the AOP infarction, along with early detection, diagnosis, and treatment, can significantly improve the clinical symptoms and prognosis for this. Thank you. Thank you very much.
Lecture. So, ma'am, and who is the next speakers?
Thank you, Professor Feng Shu. And now Professor Kazunori Shibamoto is online now. So now I would like to invite Professor Shibamoto to present his topic on full endoscopic spinal surgery for lumbar disc hernia, essential knowledge and key point of operation.
Hello, can you hear me?
Yes.
I'm sorry for being late. Today I'd like to talk about the endoscopic surgery. Give me a second. Okay. Can you see my slide?
Yes, we can see the slides.
Okay. Today, I'd like to talk about the endoscopic surgery, spinal surgeries. First of all, I'd like to talk about gastroscope because gastroscope is the most famous and the classical endoscope in medical field. So gastroscope can arrive at the intrastomach space using the original cavity like oral mouth and esophagus. This image is the tip of the gastroscope. There are some channels. First one is the lens, and the second one is the light, and the third one is the channels. Forceps, scissors, probe, or other instrument can pass through this channel and arrive at the intrastomach space. So nowadays, very early stage gastric cancer can be resected by gastroscope. This is very, very less invasive surgery because there is no skin incision and no injury of normal tissue. So how is the other field? Now, cholecystectomy, almost 100% of cholecystectomy is performed by endoscope. To approach to the intra-abdominal space, there is no original pathway, so we have to make 2 or 3 small skin incision. Joint scope is same, so this operation is invasive than gastroscope, but less invasive than open surgery. So the ratio of endoscopic surgeries are increasing except for neurosurgery. In intracranial region, the indication of endoscopic surgery are limited in pituitary disorders, hydrocephalus, intracerebral hemorrhage, and a part of skull-base tumor. Spine field is almost the same situations. So now, lab method is still gold standard procedure for lumbar disc hernia. So I'd like to show you the short video. This video was taken about 15 years ago. Operator is me, and now I'm drawing the inferior border of the L4 lamina and detaching the yellow ligament from the lamina. This yellow membrane is a yellow ligament itself. Now this ligament is detached from the bone and dissect this ligament from the dura mater. And then this white membrane is the dural sac, and usually there are many venous plexus besides the dural mater. So now I'm coagulating this plexus. And then nerve root is protected by retractor, and the surface of the disc hernia is exposed, and I'm cutting the surface with knife and resect the hernia itself piece by piece. And this is almost final view. This is L5 nerve root and the dural sac. So lab method is now still gold standard in Japan because once you can acquire basic skills, you can do it very easily, and the results are almost excellent. However, it requires at least 4 cm skin incision and 5 to 10 days hospital stay. and the patient has to endure the post-operative pain. Using a microscope can minimize the skin incision to minimum 4 cm, but the wound aches and it takes several days to recover. So about 13 years ago, I was wondering, was there any much less invasive procedure? At the time, my mentor, Professor Mizuno, told me the answer was endoscopic surgery, and he taught me the surgical techniques. From now, I'd like to introduce typical two types of endoscopic spinal surgery. First one is called MED. MED is abbreviative of microendoscopic discectomy. And in this procedure, you put the tube like this. The diameter is about 2 centimeters, and insert the endoscope into the bottom of the tube, and you control the suction and drill in this tube. This procedure is a pioneer of endoscopic spinal surgery, but now the number of this procedure is decreasing because operative field is not so clear and the higher risk of dural injury. Second one is called FELD. This is FELD is come from full endoscopic lumbar discectomy. This is an endoscope itself. Now, this is a major method. The diameter of endoscope is about 8 millimeters, and this is the tip of the endoscope. There are three ports. Largest one is for instrument, and second one is the irrigation port. So normal saline pass through this port and irrigate the operative field all the time during the operation. And the third one is the lens and camera head attached to the tail of the endoscope. This is the scar of skin incision about 1 centimeter, and this small scar is the drainage insertion. Now, throughout Japan, endoscopic surgery is less than 10% of full lumbar disc hernia operation because the number of operators is limited. It takes time to acquire these skills, and learning curve is usually steep. However, it requires only 1 centimeter skin incision and minimum 2 days hospital stay. Post-operative pain is trivial. There are 3 types of approach. First one is transforaminal approach. As this name indicates, endoscope arrive at the hernia through the intervertebral foramen. So insertion point is usually about 10 centimeters from the midline. I want to show the short video. First step is needle insertion. Needle was put into the disc space under fluoroscopic images, and I inject the dye into the disc and put the guide wire and make skin incision. This length is about 1 centimeter. And then dilator and sheath was inserted over the guide wire. The tip of the sheath is now intra-disc space, and endoscope is introduced into the disc. This white membrane is disc hernia itself. So sometimes I coagulate the disc tissue and reject the disc hernia piece by piece. This is almost final view. The upper side of bundle tissue is the posterior longitudinal ligament. So just after operation, leg pain completely disappeared. Second approach is interlaminar approach. As this name indicates, endoscope pass through interlaminar space. Interlaminar space is here. I show you short video. So usually Japanese interlaminar space is narrow. So we enlarge the interlaminar space by drilling the lamina. And this yellow membrane is yellow ligament. And cut the yellow ligament and open the spinal intraspinal space. This white membrane is dural sac. And I entered into the intraspinal space, and this pinkish one is nerve root, and blue one is disc hernia. So I continue this procedure. Sometimes large fragment is coming out like this. And this is final view. This is a S1 nerve root and dural sac. Post-operative images, hernia disappeared, and here is this is the laminectomies. I opened this space. And the third one is posterolateral approach. This approach is very similar with the transforaminal approach. This case is intraforaminal hernia. I put the endoscope directly into the hernia. This blue one is hernia. And then nerve root appeared. But there are a lot of hernia just medial side of nerve root. This bone structure disrupt me, so I drilled out and make surgical corridor. And then I remove the hernia fragment. This is final view. So hernia is completely disappeared. So this is my case series during last 6 years. Blue part is micro lab method, and brown part is endoscopic surgery. So over 90% of lumbar disc hernia can be treated by endoscope. But I talked about only good things of endoscopic surgery so far. So, but I have caution for the audience. My message is endoscopic surgery is not all-round prayer. So today, I have the limitation of time, so I don't say anything about complications, but endoscope has the limitations. So don't overdo it. So we can operate over 90% of cases, but we cannot operate 100% cases. So we have to know limitations. So conclusion, most of lumbar disc hernia can be treated by endoscopic surgery. There is a steep and long learning curve. However, once you acquire these techniques, you can contribute patients who hope less invasive surgery. Thank you for listening.
Thank you, Professor Shibamoto, for your
Thank you.
excellent lecture.
So, I'm
柴本先生。
sorry. はい。
あ、
ちょっとごめんなさい。
Thank you very much.
共有の止め方がわからなくてごめんなさい。もう画面戻ってますか、今。
まだ戻ってないです。
ちょっとごめんなさい。どういうふうにしたら。
でも先生の顔見えてるから大丈夫です。Thank you very much for your great talk, Shiro Sensei. Just I want to ask, do you have, you are Japanese, then do you have any training system for the endoscopic spinal surgery?
First 10 case, I was taught by Dr. Mizuno directly, but from 11th case, I did by myself without any instructor. So I watched many videos and I participated to cadaver seminar. So at least 10 times. So I trained by myself.
Okay, so who is Dr. Mizuno? Your teacher?
Yes, Mizuno, Dr. Mizuno is Junichi Mizuno, your friend.
Okay, thank you. Expert of the spinal surgery. Yeah?
Yes.
Okay, thanks. Tariq? Any comment? Spinal endoscopic surgery.
No, yes, thanks so much. It's obviously the learning curve is there for any type of new techniques. Spinal endoscopic surgery in Pakistan is also now on the rise, and a number of centers, even in Peshawar, are doing endoscopic spinal surgery. But again, as I say, that there is a learning curve. Initially, it takes a very long time, and then once you are good at it, it becomes like any other surgery, very quick and very effective. And obviously, it is much safer and less painful for the patient as well to be able to mobilize and go home maybe the same day. Thank you.
Thank you.
Thanks. Ikecha from Nigeria. Any comment or any inquiry? Dr. Sam, please.
Hi, Prof.
Sam?
Kato. Thank you.
Hi,
Thank you.
how are you?
That
Yeah.
was a very interesting endoscopic lecture. I would like to ask, Prof, if what do you think about endoscopic fusion? I think that one is the one which is a bit controversial, whether if you do minimally invasive versus the open or MIS tubular technique, because of the smaller footprint of the cage. What are your comments on it? Thanks.
Very good questions. Now, I'm very doubtful about the endoscopic fusion because to complete the fixation surgery, we have to use pedicle screw. Pedicle screw is already invasive. So if you can put the cage much less invasive, but the pedicle screw is huge invasive. So totally almost the same. This is my current idea.
Okay, thanks.
Oh, wait.
So now we can move on to the last presentation by Dr. Zazid Arfian. He will be talking about hybrid use of endoscopy in transsphenoidal surgery.
Thank you so much, Dr. Pham. I'll share my screen. Can you hear me?
Yes.
Yeah. Good morning and good afternoon to everyone. Depends where are you watching from. I'm Yazid Al-Dufian from King Faisal Specialist Hospital, Riyadh, Saudi Arabia. So today I'll be talking briefly about the hybrid use of endoscopy in transsphenoidal approaches. I'm going to go through the history of transsphenoidal surgery and give a little bit of talk about transsphenoid approach anatomy, and then we'll try to compare the microsurgical versus endoscopic approaches, and then we will talk a little bit about the benefits of adding endoscopy into the procedure, making it the hybrid transsphenoidal approach. So I have no conflict of interest. So transsphenoidal surgery started early in 19 by Victor Horsley when he performed his first pituitary surgery. It was transcranial actually at that time. Then Professor Schloffer, he did the first transsphenoidal approach. It was through external rhinotomy. Cushing, he is considered to be the father of transsphenoidal. He described his first transsphenoidal approach in 1910. Then it has been modified by Professor Norman Dott, and then they started the microscope by actually Professor Hardy in 1960, and then we started to call it microsurgical transsphenoidal. Prior to the use of microsurgery, there was severe limitation, and the neurosurgeon at that time, they tend to deviate toward a transcranial approach. After Hardy using the microscope, we in the literature we noticed that more transsphenoidal approach becomes standard for pituitary cases. And then the Pittsburgh group introduced the endoscopic transsphenoidal surgery as a pure endoscopic. So for transsphenoidal cases, we can approach it through the microscope, direct microscopic transsphenoidal approach, or with endoscopic, or we can do the hybrid approach, which means that basically using the microscope to use it all the way down to the cella, open, start debulking the tumor, and use your endoscopy for further examination of for any residual of the tumor, or to appreciate if there is any CSF leak. It gives the advantage of maintaining your microsurgical bimanual skills, and plus having the good visualization of the endoscope when you need it mostly, which is inside the cella. So the definition of the hybrid transsphenoidal approach would be the using microscope to approach the pituitary, cella, and paracellular region, and merge it with the three-dimensional visualization, and using endoscope for wide panoramic angle illumination. So prior to any transsphenoidal surgery, regardless of the approach, there are many factors that is important to consider. The sphenoid sinus anatomy, it is very important to appreciate sphenoid sinus prior to plan your surgery. What type of sphenoid sinus? Is it pneumatized or not? What about the septums in the sphenoid sinus? So that can be done using CT paranasal sinuses in a high resolution bone window. The carotid anatomy is also an important, it is very important to appreciate the carotid prior to your surgery. The intercarotid distance must be recognized before starting a pituitary case. Mostly the pituitary lesion would push the carotid a little bit laterally, but in some cases there will be a very short intercarotid distance. We can see it in the middle image. For example, it is like less than around 8 millimeter, and that should raise a lot of concern about how to approach the pituitary in that case. A tumor configuration and extension is also very important to decide your approach. If the tumor is extending all the way up supracellular, you might consider that you will need something to visualize way superior. So endoscopy might be superior than microscopic according to the literature. Cavernous sinus, the literature, there is nothing to prioritize for a cavernous sinus adenoma, pituitary adenoma that's extending into the cavernous sinus. There is nothing superior. If you use the microscope or the endoscope, results are more or less the same. So the transsphenoidal surgery has been staged by Professor Kanaan. He divided it into 4 stages. Would be the first stage going through the nasal part, and the second stage for the sphenoidal segment, sphenoidal part, and third stage would be the sella and the tumor, and including the medial wall of the cavernous sinus, and stage 4 would be the supracellular and paracellular extension, in case if there is an extension. So the anatomy of the transsphenoidal approach anatomy is very important, regardless of what approach you will use. Each patient differs from others. We can appreciate here, for example, the proximity of the pituitary gland from the carotid. These images are taken from rotten collection. Having good images pre-operative will help you to make the procedure safer, especially if you have a good vascular images and good understanding of the anatomy. We have always to watch for the sphenoid septums, as it might deviate us away from the midline, and it's better to have a good look prior to surgery into the CT to evaluate the sphenoidal septums. Here are the different types of sphenoid sinus. We can see the conchal type, which requires a lot of drilling, and you might deviate a little bit laterally. The precellular type as well, it prevents you from reaching the floor of the cella, so further drilling is usually needed. For the other parts, usually the procedure can be carried out easily and smoothly without any issues. But for the for the conchal type and the precellular type, it needs to be identified preoperatively to plan the surgical approach. So for any transsphenoidal cases, we have to go with a good MRI protocol preoperatively, looking for the tumor, extension of the tumor, where is the pituitary gland, and what about the carotid and the intercarotid distance. And CT paranasal sinuses, we mentioned it, it's very important because it is the approach itself. The whole approach can be seen by only CT paranasal sinuses. The MRI usually will only give, will only guide us once we open the cella. Of course, definitely we need to go for hormonal profile, and we do endocrinological evaluation. Going for a patient with acromegaly is different than going for a non-functioning adenoma. You might be more aggressive in a case of acromegaly in comparison to a non-functioning pituitary adenoma. A preoperative ophthalmological evaluation is also important to evaluate the status of the vision and if there is any visual field deficits preoperatively. So this paper has been recently published in February 2025. It compares the microscopic and endoscopic and the hybrid approach in cases of transsphenoidal. This paper was published by Professor Caldwell, and he talked about many aspects. The paper was mainly about the cost, but we can see a good secondary outcomes that we can compare with it. So regarding visualization, the microscopic approach does offer a very narrow view, limited supracellular and cavernous reach as a visualization. And endoscopic has, it will overcome these issues with the angled scopes. You can reach higher up, you can approach the supracellular lesions easier. So having a hybrid approach, which adding endoscope to the microscopic approach will mitigate the disadvantage of the microscopic approach. Regarding the dissection technique, in a microscopic approach, usually you can get the bimanual microsurgical techniques that most of the neurosurgeons are used to it and well trained for it. In the endoscopic approach, it has a different techniques, and there will be some instrument crowding might limit a neurosurgeon from having his usual techniques. In hybrid approach, usually the use of the endoscope would be only for examination and visualization, and then he will use his bimanual dissection. Regarding the nasal trauma and the stage 1, in microscopic approach, usually it is less traumatic, lower mucosal disruption, and the only disadvantage is that sometimes it might take more retraction. You need more retraction for that. In endoscopic approach, most of the endoscopic cases, usually they would take the turbinate. It's more destructive surgery. The hybrid approach is basically for the nasal trauma will be exactly the same as the microscopic approach, because introducing the microscope usually from either from the ipsilateral nostril that we're using or from the other nostril, it does not require that much of mucosal damaging. For the learning curve, usually the microscopic approach is very familiar. The neurosurgeons are familiar to the microscopic approach. Endoscopic would need a steep learning curve. For the hybrid approach, it's exactly the same as a microscope. For operative time, this is very important. The microscopic approach is the shortest in time, and the endoscopic approach is the longest in time. So what about the hybrid approach? In this series, in this paper, it was mentioned that the hybrid approach took longer time than the microscopic approach, and that has some questions about it, because basically we're doing microsurgical approach and we are only having the endoscope for examination mostly. Probably this increase in time is because of further evaluation of the cella and finding some tumors hidden under diaphragm, which require further more time to resect it, and that might explain the longer time. For hospital stay, there was no significant change. It was mentioned that the microscopic approach might be longer, but the numbers are not consistent. For cost, the microscopic approach has the lowest cost, and the endoscopic approach is the highest cost. So a microscopic approach is good for routine pituitary adenomas, and the endoscopic approach might be better for extended or supracellular cavernous sinus invasion. The hybrid approach might give you the same things that endoscopic approach is giving, with a little bit of limitations. So here they compared also the outcomes, endocrinological outcomes from the different techniques regarding the new postoperative hypopituitarism. The data were not consistent, and there was no much difference between the endoscopic and the microscopic groups in all the literatures. The long-term DI was also the same for both groups. it was not the termination and normalization of hypersecretion, however, it was reported to be around from 55 till 75 for all. The tumor recurrence and remnant in these literatures was not, there is no significant change in between microscopic nor endoscopic. So here we will go through a quick case where microscope or hybrid approach was used. So basically this is a 31-year-old woman not known to have any previous medical illness. She underwent rhinoplasty 2 years ago. And then she came complaining of several months of headache and progressive bilateral visual decline. She was found to have severe bitemporal hemianopsia. Hormonal evaluation was unremarkable, except of mildly elevated prolactin level, which was expected. So here is the CT for paranasal sinuses to evaluate the sphenoid sinus preoperatively. We can appreciate the septum. The sphenoid sinus was well pneumatized. This is the MRI that showed the pituitary lesion compressing the chiasm. Here we are performing microscopic transsphenoidal approach. We introduce the nasal speculum. Then we inject the septal mucosa, and then we made a vertical cut through the septal mucosa, and we push the mucosa laterally, and then here we are pushing the mucosa laterally, and then we will push the septum toward the other side. We can appreciate that the sphenoid ostium was already widened. Probably that's because of her previous nasal surgery. But we can see remnant of sphenoid face there. So drilling of the sphenoid face is done. And we can see there that the sphenoidal mucosa, was removed. And usually it's sent for culture just to identify if there is any MRSA or something in case of further antibiotic treatment is needed. Here we can see the anterior cellular wall and the floor of the cella. Then we will do the eggshell drilling of the anterior and floor of the cella. Here we are using the navigation also to confirm our site and our midline as well. So usually we do eggshell drilling for the anterior cellular wall and the floor of the cella, and then we use the Carrison to widen our exposure laterally. Here we can appreciate the dura, and we made a cut into the dura from 6 o'clock, from 3 o'clock to 6 o'clock, and then toward 9 o'clock. We always attempt to start the procedure with extracapsular dissection using the ball dissector. we're doing hemostasis before going toward the lesion. We can appreciate the tumor was immediately in front of us. So the tumor was already easily coming out, and we sent sample immediately for final pathology, and then we use the ball dissector to bring the tumor further down, and then we would be using the curette to remove the tumor from the edges. And then it comes the difficult part when the diaphragm starts herniating down and blocking some of the tumor or hiding some of the tumor just at the edges under the diaphragm. Then we go with the curette aiming to examine it, or we can introduce the, we can see here that CSF was encountered. So what would we do? We would use the endoscope to evaluate the source of this leak, because here it's not very clearly demonstrated. So this is the endoscopy when it was introduced through the same approach. We can appreciate the stalk here and the defect in the diaphragm. Then we'll try to repair the diaphragm. Usually we'll use a hemostatic agent and fat graft and applying some sort of fibrin glue. This patient recovered well after surgery. There was no CSF leak and discharged home day 3 post-op. Thank you so much.
Thank you, Professor Yazid. If we have any discussions, comments from anyone?
Thank you, Dr. Ozgan. Dr. Ozgan?
Hello, Sensei.
Yes, question? Thank you.
There's no question. Thank you for this great presentation. There's no question. Thank you.
Thank you.
Okay.
Great
Yes,
talk.
we have
Thanks.
Stephen Tandin who is raising his hand. Yes, Dr. Stephen Tandin.
Kazunori Sensei, please.
Thank you so much for the opportunity. I would like to ask for the study, do you do it together with the ENT surgeon, or you as a neurosurgeon done it by yourself, or you join with the ENT surgeon? Because some we know that some center join together with the ENT, some center doing alone as a neurosurgeon. Thank you so much.
Mm-hmm. Okay, so regarding for the hybrid approach, it's done purely by neurosurgeons, but for the endoscopic approach, it depends on the case and the extent of the approach. If a very extended approach is needed, we would go with the help of our colleagues from ENT. Otherwise, it can be done by a neurosurgeon here. It's for a standard pituitary lesion. But if, for example, we're aiming for the tuberculum cell meningioma or the anterior fossa, then most likely we will be calling our colleagues from ENT.
Thank you so much.
Thank you so much.
Yes, Professor Kazunori.
Yes, Kazunori Sensei.
Thank you for good lectures. Hybrid surgery is very ideal, but I have a question for you. How is the preparation? You have to prepare the endoscope and the microscope both, so the operative room is a little bit jammed and crowded. So how do you think about this? So is it a little bothersome for you or not at all?
Sorry, Prof, I'm not sure if I understand your question, but if it's about the use of endoscope in microscopic case, the role of the endoscope here is usually for visualization. Usually we go there, visualize, examine the area, come out with the endoscope, then go back again with a microscope. Sometimes you will be able to use the endoscope and one more instrument, it's possible. But yeah, we cannot use endoscope and two more instruments in the hybrid approach. But because the role of the endoscope is just for visualization and examination, and then we'll utilize the microscopic approach.
先生のご質問は良かったですかこれで。
So my question is, there are many instruments in the operative room. So if your room is not wide, so it's a little bothersome because there are both microscope and endoscope. So my question is this.
先生、ちょっと日本語で言ってもらっていい？通
ごめんなさい、
訳するから。
マイクロと内視鏡と両方あったら、手術室がごちゃごちゃして、すごいやりにくくないですかっていうことなんですけど。
じゃないかということ？部屋が狭くなっちゃう？
そうやりにくくないですかという。
So his question is if you have a microscope and endoscope at one room, it is so tight, so busy in the room. So do you think is it
Okay.
easy to operate?
Yeah. Well, I don't think that of a problem actually. I would have a crowded room rather than a crowded field, so it's not a big problem. It depends on the way they set the endoscope, but it's usually never a problem.
I got it. Thank you.
Thank you so much, Victor.
Right.
Thank you,
If there are
Raja.
no further questions, then we can move on to our honorable chair and speaker, Professor Tariq Khan, who will be talking next on TBI as a notifiable and chronic condition. Professor Tariq is a man who doesn't need any information. He is the Dean of Northwestern School of Medicine located in Peshawar, Pakistan, and Professor and Head of Department of Neurosurgery at Northwestern General Hospital and Research Center. He was the Chairman of Neurotraumatology Committee of the WFNS and also the Chairman of the Alliance of Healthcare Limited Pakistan. He was a past President of the Pakistan Society of Neurosurgeons, and he is a member of the Neurotrauma Committee and faculty for Asia Australasia Society of Neurological Surgeons, as well as Medical and Dental Academic Board of Pakistan, and he is a convener for Neurotrauma Committee in Pakistan also. So, Professor Tariq, we are extremely honored to have you today with us. Please go ahead with your lecture.
Thanks so much, Raja, for the introduction. So I am going to talk a little different because I'm going to talk about policy. I hope you can see my slides.
Yes.
Yeah, and so what I'm trying to talk about is to get the World Health Assembly to get recognition as traumatic brain injury as a chronic and notifiable condition so that we can bring it to the center of policy research and rehabilitation. This is where I work, so no conflict of interests. So for me, it started when I was sent a paper by Professor Andrew Maas. This paper was published in Pakistan, and it showed the patients with mortality and morbidity from different diseases. And the traumatic brain injury was nowhere to be seen in that paper. And we know for a fact, and similarly in international journals, if you see that you cannot see traumatic brain injury as the top 10 causes of disease. Although we know from what we see that how much traumatic brain injuries occur in our hospitals, patients coming in. Obviously, that's not true that it's not in the top 10 conditions. We know that traumatic brain injury is a major cause of death and disability more than HIV, AIDS, and malaria combined nowadays. But these all figures are extrapolated figures. We do not have a database to find out traumatic brain injuries, and especially most important is the minor traumatic brain injuries, which are not at all recorded. From what I gather, the only country which is doing maintaining a database for traumatic brain injury is probably Australia, if I'm not wrong, and a few states in the United States. So, as I said, that it is a leading cause of death and disability. Despite this, it is underdiagnosed, underreported, and underprioritized in national health data systems. Without mandatory notification, health systems cannot accurately measure or respond to the true burden of TBI. So there's evidence from long-term neurorehabilitation studies and patient narratives that TBI survivors suffer from cognitive decline, depression, personality changes, and social isolation, and experience ongoing medical needs dependence on family or caregiver and loss of employment. They often lack access to follow-up services, especially in LMIC settings, leading to poor reintegration and long-term disability. So declaring traumatic brain injury as chronic realigns health systems to track, support, and rehabilitate survivors far beyond the acute emergency phase. So early data notification equals better prevention and care. It will allow us to have real-time surveillance of injury mechanisms, identification of hotspots and high-risk groups, and informed allocation of health resources. Obviously, this would lead to smarter investment, improved care, and reduced long-term burden on families and national health systems. Because if there's lack of follow-up care, data visibility, and support, TBI becomes invisible in policy, which means that it is neglected. And as I said, data from Australia and a few places in USA shows that reporting leads to real change. So how would a WHO resolution on TBI as a notifiable and chronic condition, what would it achieve? It would place traumatic brain injury formally on the global health agenda. It would send a signal that TBI matters, not just clinically, which is very important, but as the public health priority deserving sustained attention and funding. It would correct long-standing policy blind spots where TBI been left out of major health strategies. To improve surveillance and data systems, can you hear me?
Yes, of course.
Hello?
Yes, Prof. We can hear you well. Please go ahead.
Okay. So TBI would be systematically tracked, just like polio, TB, or maternal disease, and better data would cause early intervention, smarter resource allocation, targeted prevention strategies. It would help quantify the true burden of TBI, especially in LMICs, where it is currently underreported or not reported. And this policy would help in classifying TB as chronic condition in national health frameworks, integrate TBI into notifiable disease lists, allocate budgets for rehabilitation, long-term care, and district systems, and the resolution provides a legitimized framework for ministries of health to act and implement reform. And would help access to technical guidance from the WHO. It would align with donor priorities regarding road safety, disability rights, rehabilitation, and of course, potential for inclusion in World Bank or UNDP health portfolios. And it would increase the chances for pooled global investment into TBI prevention, rehab, and research. Of course, the most important people who have had lived experiences, it would give them a critical role and with their families also. And it will involve the people with lived experiences in designing, implementing, and monitoring national TBI strategies. So it's important, of course, to involve them in the daily lives of TBI every day. It is ambitious but achievable. World Health Assembly resolution demands sustained political and diplomatic commitment, but so did past global successes like mental health, hepatitis elimination, and polio eradication. It's not just a symbolic gesture, it is a vehicle for change, because what gets counted gets funded, and what gets funded gets fixed. It transforms TBI from an invisible crisis into a trackable, fundable, and manageable health condition. And we have been through all these now. We started off with these definitions, and now we are doing public awareness, and we have got countries involved in this mechanism. It started off, we did in September in the INTS 2024 with Pakistan, UK, and Canada. And today we have more than 80 plus organizations who are part of this coalition from more than 100 countries. So within 6 to 8 months, it has been a big achievement. The Ministry of Health of Pakistan has formally agreed to sponsor the resolution. And as I said to you, Indonesian government has also agreed to support this resolution. And we are engaging many other countries. And we are looking to the people who are on the webinar, whether they're faculty or whether they're students, to want to encourage them to help us do this more. We've already prepared the draft resolution for the traumatic brain injury as a distinct global health priority, notifiable, chronic, and preventable. This was our first public international seminar in Geneva. You will recognize some of the people there. The representatives from many organizations and from the government of Pakistan were there in Geneva on the sidelines of the World Health Assembly in May this year. So this was the coalition. So the coalition, importantly, is not just neurosurgeons. It is a coalition of allied health sciences, of general surgeons, of nurses, of many other organizations, anesthetists, and other organizations who are interested in prevention, acute care, and rehabilitation for traumatic brain injury to do that. And as I said, recently we met the health minister, Mr. Puri, in Jakarta, and he agreed to support this resolution as well. So we are on fast track, and we hope that other countries are going to join us very soon as well. We are going to be talking about it in the Eastern Mediterranean Regional Office meeting in Cairo in October. And we have just done a seminar at the UN General Assembly in New York a few weeks back. And also, we're going to be talking in Fiji, Western Pacific meeting, where Indonesia, the Asrad Fauzi is going to present it there. And then we are hoping to have a 1-hour discussion on this on the 1st of December in Dubai WFNS meeting. Anybody who wants to get in touch with me, please do so that we can have more partners in joining up to make traumatic brain injury as a notifiable and chronic condition. Thank you very much.
Thank you, Professor Tariq Khan, for this very wonderful initiative. I'm aware about it, and I know that there are several countries that support you. Of course, the ACNS can be a very valuable partner for you, with the permission of our Honorable President, Professor Yoko Kato. Of course, we'll be there in Dubai. Hope to see you in person. Prof. Kato, any comments from you?
Thank you very much, Dr. Tariq. So nice continuous year endeavor, the work of the trauma. Yes. So as ACNS, we have the 15th ACNS will be held in Mumbai next year, around July, I think. So we can invite you. Maybe you can have some conduct some such kind of workshop for some lectures. It's very, very important because Mumbai is one of the most frequent traumatic trauma, I think. Just I will ask because what about helmet wearing? So in the world, is it custom in the world? How do you think about?
Yes, of course. Prevention, as I said, is the most important aspect of traumatic brain injury. Majority of the head injuries, especially in the lower and middle income countries, are due to lack of head helmets and seat belts. And we have seen the example of Hanoi, where they decided, with the help of the WHO, with the help of a few other organizations, they were able to, with USAID, they were able to make sure that everybody wears a helmet. And once that started, I think it was 1997, I'm not sure of the exact year, there was a dramatic fall in traumatic brain injuries from motorbike accidents. So definitely that is what we have been promoting. We recently had many public awareness seminars where we distributed helmets, but enforcement is the biggest problem. Enforcement also, but for people to understand the importance of wearing helmets and seat belts. I think that is more important. Thank you.
Thank you. Now in Japan, since last year, even about the ride a bicycle, the obligation to wear the helmet, not a motorbike, cycle, bicycle. Yes. Thank you very much. Wonderful talk.
In Europe, the people who are on scooties, they are not wearing helmets. I believe that is even more dangerous.
Okay, thanks. Roger?
Yes, Sensei. So thank you very much. If there are any comments from anyone else, you are most welcome. You cannot see any raised hands so far. Wifam, would you like to say something since you are from Vietnam? Hanoi?
Yeah, I have learned a lot from this webinar like this from different speakers from different parts of the world. And I hope that I can join the webinar like this more and more in the future.
Thank you very much. We have Dr. Anyaku from Africa. Please say something. No comments from
Yeah.
you? Okay, fine. So then we can close now, Prof?
Yeah, I think so. So, Dr. Tariq, thank you very much for this is not exactly the replace, but I think we are very honored to welcome you as the chair and president of the ACNS World YNS Web the Symposium. So I think especially the developing countries, YNS need more knowledge and skills in the future. So I think only these the lecture is not enough, but I think maybe in the future, hands-on or in person, of course, hands-on workshop or lectures more and more. So please join us forever. Thank you very much.
Thank you
Wonderful
very much.
symposium today. Thanks.
Prof. Tariq, any closing remarks from you?
Yes.
Thank you so much, everybody. Thanks to all the faculty speakers and the people who were joining to listening. Webinar symposiums since COVID time have had its own very great significance because many young neurosurgeons are very hungry for knowledge, but they cannot travel to different places. It's not a substitute, obviously, for hands-on. It's not a substitute for face-to-face meetings, which have its own very great significance. But such webinars, web symposiums go a long way in helping those young neurosurgeons from lower-income countries who are not able to travel, mostly due to financial reasons and other reasons as well. So I think a combination of web symposiums, hands-on, and physical meetings, I think it's a great combination. And thanks to the organizers for all the efforts which we have put in the last few months to ensure that there was a great collection of great speakers who were able to impart a lot of knowledge to all the young people. Thank you so much.
Thank you. Thank you so much, Prof. Tariq, for those nice words. We would like to inform our viewers that the ACNS YouTube hosts all these webinars, and it is archived on our YouTube channel. More than 680 episodes with over 3,000 lectures by exceptionally good neurosurgeons from all over the world. Thanks to our Honorable President Prof. Yoko Kato for her never-ending support and push for online education that we are able to carry on for this long, since 5 years it's been now. And thanks to all the wonderful speakers who have joined us today, and thanks to our moderators, Huifam, Ben, Dr. Liu, and Joe, who have joined us. And with that, we come to the close of this wonderful ACNS World YNS Symposium. Thank you very much, everyone, for joining.
Okay.
Bye-bye.
See you soon, Tariq. Thank you very
Bye-bye.
much.
Thank
Bye.
you.